is by the county staff. So the other thing that we do other than HIV is now issues of chronic disease, and that is diabetes, hypertension, and currently we're having discussion led by Lutodo on the integration of HIV services to other chronic diseases. Of course, we do cervical cancer screening, and we therefore change our name. There's a time we had a grant that was working on primary healthcare, and we still do. We support Trans Nzoia, Uasin Gishu, and Elgeyo Marakwet. Unfortunately, that fund is not with West Pokot, but occasionally when we have activities related to primary healthcare, yes, we do support, like we train some community health, the community strategy for the East. So we then change our name to Academic Model Providing Access to Healthcare. It's still the same name. So it is us who know where we have come from and where we are going. So I think having said who we are as AMPAT, especially for those of you who may not know, is then to say through our integrated services, we have enjoyed a cordial working relationship with the county. And first of all, let me appreciate the county leadership through the CEC, and particularly to the governor, because we have seen a number of changes in the Nation of Health Services work. I've had a lot of discussions with the chief occasionally, and we want to appreciate then that this current leadership, just like he did when he was in the as healthcare delivery is concerned. So we really need to appreciate that. He was my classmate actually in primary, sorry, in secondary. You know, we are talking about primary healthcare. From Form 1 to Form 4, we suffered together. And this is the second time I'm meeting him since then. The first one was during a Kemri meeting, and I thought he was still in Kemri. Among the 4 counties that Tusima supports in this region, we get like 10% of what Trans Nzoia receives in HIV care. And the last 2 days, that was Monday and Tuesday, we had meetings. And we were being told in West Pokot, and the funds is going down over time. So we will have a discussion on how we can achieve the same results with the reduced funding. But what is the reason? They say there's no HIV in West Pokot. So the funding is based on the number of HIV cases in care. And this is based on estimates. The estimates that, for example, we are working on now is 3,266. But people who may be having HIV out there, but we have not reached them. And the issue really is, if you don't have a test, you can present with any other signs and symptoms, and we confirm these once with the man who was in the house. He had been, people had run away from because he was wasting. It was negative. So we took him then to the hospital, and he was actually diabetic. Home still thinks about AMPAT because we saved someone who was actually going to die. And all he needed was to know is a challenge we have, stigma, people fearing to be tested. And those are the biggest challenges we have again. And test as many people as possible. We should be able to know what HIV infected patients in West Pokot. And again, because of the little funding, we may not be able to do that, but partnering with the county and training the staff, and we should be able to do it across the county. We will even know which part of the county has the highest prevalence of HIV. Right now, there are places we can't reach, not because we are not, is among the country that is leading in transmission through the community strategy and issues. So I know I can give a lot of stories, but let me stop there And actually, with one last issue, I said the county is doing very well in terms of under the current leadership, but I know we still have challenges in infrastructure. We'll come to you, Director, for example, to discuss issues of office space. We are told, let us take the money, for example, to support operations. If we can get an office in the county, and that is where infrastructure issues come in. Of course, we know HRH are also other challenges, but I know the county leadership is addressing it. So we're happy to be here. Thank you very much.
Thank you, Daktari. I'm informed we have the county director of Enterprise is here. Karibu tafadhali. Come and introduce yourself and make brief remarks.
Thank you very much, the county leadership. My name is Peter Ufware. I'm the country director for Health Right Kenya. We have had a long history as Health Right Kenya working in West Pokot. Actually, we are one of the few NGOs or international and local NGOs that set up their headquarters in Kitale. And then we were able to access West Pokot for many years now, almost 35 or so years, when we worked mostly in West Pokot, Elgeyo Marakwet, Trans Nzoia, Bungoma. So we are almost known as an organization that works in the North Rift. I am happy to be here today as the country director of Health Right because the county government of West Pokot have always valued health rights work in West Pokot. And the people come where we are now in Nairobi and they tell me I went to West Pokot and people are asking about health rights. Where are you? But we are still here. We are working very closely with partners. As the AMPATH leadership said, money is becoming, or the donor money is becoming dwindling. And as organizations, we need to start rethinking new strategies of partnerships. How then do we partner with other organizations to do other things, or even co-create and coordinate the activities that we do within the counties? Secondly, I'd like to say that as Health Right in Kenya, we focus on 4 thematic areas. Reproductive, maternal, newborn, and child health. We also do gender-based violence, and we do HIV, but also do mental health. And that mental health area is where, as Health Right, we do one of the things that most of the organizations don't do. Currently, we have a program in Nairobi that is supporting perinatal mental health in a number of slum areas in Nairobi, funded by Comic Relief. We are also soon starting a project in your neighboring county here. Of course, it's not really very neighboring, but Bungoma County, not far from here, or from West Pokot, on GBV integrated with mental health. And we have written a number of proposals targeting the margin, because we work with the so-called marginalized. Sometimes are difficult to describe, but marginalization can come in different ways. Can be women, can be people who have no access to health facilities or water or other amenities. It can be people who have been neglected by government. I'm not saying the county government cannot. Since the county government came into being, I think they have done a tremendous job in trying to reach even the farthest pockets of the county. I've had a history personally before I joined Health Right. We also implemented some programs with AMREF in West Pokot County, and I know that a number of people here that we worked working very closely with the county team. We can co-create, we can write proposals, and by all. Now I think Silas is there, we are working on a TB proposal. And we are interested in co-creating that understands what is happening within the county for the people within the county. With those few remarks, I would like to say asante sana for inviting us. And even though we don't have a current project that is running within the county, proposals, and we can bring resources when we work together. With those few remarks, I would like to say thank you very much. God bless you. We are still here. We are going to interact.
Thank you so much.
Yeah, so just to be brief, so our vision is to see a world in which no one is needlessly blind or vision impaired, and in particular in this context, West Pokot. So we want to make sure that everyone has access to high quality, affordable eye health care in West Pokot, especially the vulnerable communities. So as I had mentioned, we implemented the trachoma elimination program. This was from 2012 to 2022. And we are currently implementing the integrated eye health project for underserved rural populations in Kenya. So it's basically an eye health NGO, much. Yeah. So the project is anchored on the WHO health system strengthening framework and is designed to make eye health an integral part of UHC, a key flagship of the Kenya government. So what do we aim to see in West Pokot? Of course, eye health seeking behavior is improved as a result of effective integration of eye health into community and primary eye care. High quality comprehensive eye health services are available and accessible through static and outreach programs. So we also focus on uncorrected refractive errors and childhood blindness. A culture of quality is embedded within the CHMT and hospitals to improve patient outcomes and uptake of eye health services. We also aim to see improved management of eye health to achieve sustained service improvements, equitable and also equitable access of eye health services for most vulnerable, especially women and elderly, together with people with disabilities. So we are basically an eye health NGO, implementing eye health in all the 6 sub-counties, just ensuring our services reach the farthest vulnerable people in West Pokot. So I won't say much because 1 minute is basically over. But naweza nipata nyuma ya tent, I can always explain more about the foundation. Yes.
Thank you so much. IRC.
His Excellency Bwana Waziri, the chief officer, directors, the CHMT team are present, the CHPs, representatives from partners, all protocol observed, ladies and gentlemen, good morning. How are you? I can't hear you from the back. I hope you can hear me. My name is Eliza Meriabe from the International Rescue Committee. I'm here representing our Deputy Director of Program, and she was not able to come, but she sends her apologies and her regards. The IRC Kenya is honored health, policy, research, and knowledge and research to ensure comprehensive and resilient health system that ensures coverage to the last mile reach, which is a great testament that is evident in today's event, seeing all the partners and the county government come together to share, to come together to celebrate the strides made towards this effort. I'd like to commend the great efforts of the county government, MOH, and its partners in putting in place the UHC cover and rebuild their lives. In Kenya, we work in 6 counties, strengthening health system, research and knowledge sharing, strengthening health system, research and knowledge sharing, and recently as IRC countries in relation to this global movement. In West Pokot, while aligning with the county, we implemented a study titled Combined Protocol for Acute Malnutrition, which is COMPASS, with the name of improving coverage, quality and continuity of care, as well as cost effectiveness in the management of acute malnutrition. Part of the findings of this study, which was shared with the county together with the partners, include the finding that the simplified approach reduced the cost of treatment per child, amongst other findings that were identified within that particular study. As IRC, we believe in system strengthening and sustainability. As such, we are currently closely collaborating with the Department of Nutrition under the MOH to provide technical assistance towards CMAM programming within Central Pokot Sub-County, as informed by that particular COMPASS study. I once again reiterate our commitment to continue collaborating with the county and its partners to reach to our shared aspirations and overall towards a universally available health coverage. Thank you, and we are glad to be here.
So much, Makofi. Thank you so much. Yes, Kenya.
So all protocols of good morning. Yeah, so my name is Dr. James Rotich. I'm here today on behalf of Dr. Pai, who is a director for RH programs at PS Kenya. We were PSI initially from 1989, and then in alluded, and we've been in the RAMCAS so we do a lot of RH programs, and our approaches as an organization is social sector. You can't mention it without mentioning Population Services Kenya. And at this point, I just for being very progressive in terms of the leadership. And I think when you just see this step and repeat banner, you can just see that you have many partners. And I think it's because of how friendly you are and how welcoming you are to us as partners. And we want to thank you and appreciate you. Without mentioning anyone, sometimes we SIP, which is a 6-year, the final year. We are closing next year, March. And we worked together with Eltrite International that has also done a lot of work in the ground in terms of reducing
zero unmet need for FP, zero maternal death. Also established a lot of groundwork. They've managed to work through CBOs and even establishing shelters. DESIP has done a lot to create awareness through male engagement, which is one of something that has really worked well in and LMIS is just one of the last that we supported this year in May actually. And of course, we have been working with other partners to co-support some of the county level based activities like AWPs and TWGs, data review meetings, support supervisions, and other things. So we are happy to have been in West Pokot. The best achievement, of course, was the MCPR, which increased by 9 from 13.3. But I recognize that teenage pregnancies are still high at 36% and FGM at 44%. So focusing on primary care definitely is a good thing for us, even as partners and programs, because we look at this as a way to enhance sustainability of our programs. Otherwise, as an organization, we look forward to more engagement and collaborations. And just as someone had said, even if the envelope is going down, we're still available. We're still ready to provide technical support. And whenever we get resources, we'll definitely spend in this fund. Thank you so much, and God bless you.
Thank you so much. Close that program. I'm going to invite Elijah Fuji. If sorry.
Thank you, Director. I'll be very brief. The CC and all the other county leadership, the teachers, our teachers and professors in the room. I think we are some of the people who benefit from the COPS program. We are around 6 in the room. I'm sure they'll be able to reach out to you separately. So my name is Elijah Chora. I work with the COG, Council of Governors, in the Health Directorate, and I'm representing the COG today in this noble forum. We want to applaud the county for this kind of initial exhibition, and it should be annual or biannual. And we said after 6 months we do this, so that we track the performance that we're doing in the health sector in the county. Yeah, we'll be meeting the chief officers in the next few weeks, and I think we'll share this experience from West Pokot. Chief Officer Health, that's right. Thank you. So let me go to exact what I want to say. PT has been one of the things that we are moving forward to implement as a country, and therefore, for COG, working closely with the 47 counties, we ensure that the counties are aligned with the UHC agenda and suppressing these meetings together to ensure that we are supporting counties and the national teams to resolve these matters. The role of partnerships at the county level is great, and we want to continue checking that we have impact, we do impact, and efficiently utilize the resources that are given us by the donors. The respective country represented by the partner reps who have talked about this, they have talked about importance of being coming together. And Prof. Ndege, you said you were in a meeting in Kisumu and you said, how do we continue working together? So COG, we had a meeting last week, a roundtable partner meeting, and we discussed how we can have all the counties establish a similar mechanism, a similar framework, county coordination partnership framework. And we have started that together with some of the partners who have their programs funded by USAID, assisting around 10 counties, developing county partnership frameworks through AMREF. And we want to extend this to the 47 counties so that every county has a partnership engagement framework to ensure this work is properly coordinated. And this session has taken long because we are too many, and we have added value to the county health indicators, which is great. And therefore, we continue doing that through our partnership engagement framework, which we shall discuss with the director and the county leadership, how we can have this developed if it's not in place. It is important to note planning and sharing events on PHC will continue being part of the work that we are supporting closely with the counties. And counties have been categorized into various regions, and we're looking forward that how we can have the North Rift cluster be part of the cluster that is performing well in the PHC delivery, enacting laws, taking forward the investments in health, implementing the policies around primary health care, having all the strategies in place in the PCNs being operational, ensuring that they showcase what they have done in terms of ensuring that PHC is actually working on ground. And then this is going to the county leadership, the PHC teams, ensuring that this works well, as even we prepare to look at which region can host a forum. We looked at West Pokot can host this forum to start with. And therefore, partners in the room, let us put effort to ensure that all the PCNs are operational in the county, that we will be able to do this work. Ensuring that PCNs are operational is one of the critical things. I've rushed through the PCN baseline assessment report that has been worked on very well. And there are some of the indicators that we will continue reflecting and how we can track and see how that can be done well, as even we ensure the PCNs become operational at regular level. And that means the county engagement and commitment continues, and I've seen this through the financing, through the commitment of supporting this work. By actually convening this meeting, it's a commitment that the community and partners continue to commit, the county government and partners are willing to ensure that the PCNs are operational from the digitization process, working the ECHIS, ensuring that it's functional, the linking of the health facilities community effort to the EMRs so that service delivery is seamless. And those are the indicators we're talking about. At COG, we have also worked closely with some of the PHC work streams to develop a male functional matrix, a PHC measurement framework, which will be shared when it's ready. So it's about to be ready. And we'll be looking forward, how do we measure the functionality of our work? And that means that each county will be having this tool through the PHC coordinators table and seeing that working also with the partners that we ensure all those indicators are moving well. I want to call upon all the partners to support, to continue supporting the county in ensuring that all the work that we are doing well is properly coordinated, supported, and call upon all you to enhance the collaboration and coordination, to ensure that we support and making sure the PCNs are being established are operational. Establishments is one, but making sure they are operational and functioning and supporting service delivery is the best agenda we move forward. Let's ensure that we do the operational research. Remember, we have the university with us, the AMPAT with us, and other learning institutions. Let's collect evidence on what is working, what is not working, so that we can inform policy and practice in PHC. And therefore, let us also look forward to supporting some of the inter-county learning events, sharing the best practices for other counties to get and see that we can do this better, what West Pokot is doing. And this is including improvement in service delivery. Thank you so much, and I wish all the best in this engagement. And the COG is happy to be here, looking forward. Thank you so much.
Thank you so much, Makofi. We have been joined by our county secretary, Honorable Jonya Karibu sana. Yes, I want to appreciate each and every partner, and I want to categorically state that the order of me calling the partners was very random. I know the biggest issue comes with polygamous men on how they can arrange the orders or but we are one big happy family and the order was very random. So I think I will take this juncture to invite our chief officer to give remarks and welcome to you. Thank you so much.
To our CS, the CC head, chief of parties, all the representatives from the various partners supporting West Pokot County, and the representative of COG, all protocols observed. Good morning. Am I imefika afternoon? Oh, it's already afternoon. I'm Nelly Soprin. I'm the Chief Officer of the Department of Health and Sanitation in West Pokot County. And I want to take this opportunity to welcome you all to Heka Hotel for this first exhibition. And I think West Pokot County, we've been leading in one way or another. Feel most welcome. I hope you had a safe journey to this place. And for the ones that are still coming, we want to wish them journey masses as they join us. To begin with, this is something that we well thought of as a department, knowing that we are doing 11th year after devolution. It is always good to appreciate ourselves and again to track on what we've been able to achieve as a department and as county after devolution. As Department of Health, we know that we have a responsibility to provide improved health to the people of the citizen. Again, the care that we are providing should be responsive. And as a department, we majorly get resources through support of the national government, through the exchequer, and also through the partners, through the donors' support. For the 4 acts that were enacted recently, I think West Pokot County is one of the counties that would really want to ensure that we are able to actualize those acts, because we know the benefits that are going to bring to healthcare at large and West Pokot as a county. The hurdles that are there, we are praying that they are going to be overcome, because for us, especially for the marginalized counties, we know what those policies can be able to help in strengthening health system and bringing healthcare closer to our people, that is accessible, that is equitable and fair. Some counties probably that were well established before devolution may not have the urge to have this act. But for marginalized counties, we saw the 4 acts being implemented will be a big breakthrough for us. And with the support of the national government, the county governments, and for the donors supporting health, we'll be able to have a big breakthrough. So today, we thought of celebrating the efforts that we've made as a team, not as a Department of Health of West Pokot County per se, because without your support, without your closeness, without you giving yourselves the resources, we couldn't be where we are. So even for the little milestones that we've been able to achieve, it is always important that we really appreciate. Primary healthcare. We know we have primary healthcare current declaration that aims to refocus efforts on primary healthcare to ensure everyone and everywhere is able to enjoy highest possible sustainable standard of health, which is also a commemoration of the Almata Declaration. I think for some of us who went through colleges in early 90s, I think that was one of the longest definition that we had to memorize. The definition of primary healthcare for those that went through health science courses. And it is the best approach to actualize universal health coverage. And West Pokot, through the partnership that we have with you, I think we are picking these and we are getting run. West Pokot is a small county with 6 sub-counties, with 2 which we operationalized in the last 3 months, with hope that we bring management closer to our people. We are aware of what that can be able to help us. So otherwise, I'm not going to give a brief on behalf of the department or the county because I have my boss. I don't need to speak a lot. So otherwise, enjoy yourselves as we begin our first day of this exhibition. It is the first one. I know we'll be holding it probably once yearly with a broader aim of strengthening our collaboration, working closely together as a team to actualize greater performance in health. I want to appreciate all of us because where health is in the last 20 months, because we are now doing our 20th month by tomorrow. It is through the collaborative efforts that we've had with you. So feel appreciated. And I know for the remaining 3 years and few months, we will be able to actualize so much in West Pokot County. Otherwise, I want to take this opportunity to invite our CEC Health to come and give his opening remarks. Karibu.
Okay, thank you, Chief Officer for Health. Our partners who are present here today, West Pokot County staff who are here today, good afternoon. Habari yenu kule nyuma. Asante sana. Mine will be a few remarks before I just mentioned through. In my opening remarks, allowed me to recognize the presence of the County Secretary, Mr. Siwanyo, with us right now, and again to give a communication that His Excellency the Governor, His Excellency the Governor, Simon Kachabin, and the Deputy Governor, Robert Komole, will be joining us in due course. They have other commitments, and we are expecting to be with them. Otherwise, allowed me to thank our partners for the commitment we have done to attend the inaugural West Pokot County Primary Health Exhibition. We are not taking it for granted because I know it's a commitment to be here with us today. Otherwise, I'm humble and I'm very happy for you because of the commitment of time and your presence here. As Department of Health, we are looking forward to continue partnering and working closely with you. Secondly, the reason why we are here today is because of primary health care. And one of the principles of the primary health care is in the sectoral coordination, apart from equitable distribution, community participation, appropriate technology, and focus on prevention. I know we'll continue to learn from each other, interact a lot, and at the end of this exhibition, I'm very sure that we'll be able to learn a lot. And because my bosses are still coming to share a lot, I wanted to bring into attention the reason why we are here today. To be brief, we are here today as a county to celebrate with our partners. We cherish you, and we know the role you have been playing in our county. And even it is today, I realize that we are blessed to have many partners. And from the comment by Daktari Dr. Mvege, it is true that in our county we are blessed, we have many partners, but we require proper coordination so that there should not be any duplication of programs in our county. As we see, as if one partner exists, we require sustainability. So I'm looking forward from this exhibition for today that we need to have a proper coordinated way of how we can be able to undertake our programs in our county. But I know as we interact, share a lot, we'll be able to come into a conclusion. Our key meeting objective for today is to showcase county progress in primary health care. That's one of the objectives we are here today. Secondly, is again to celebrate existing partnership and reaffirm commitments. The third reason why again we are here is to align programming and the PCN rollout in the county of West Pokot. And finally, our partners, we're here again today to define critical gaps and identify opportunities to address them. I know for the 4 acts, every county are looking forward towards operationalization or implementation of the same. And I know there are some gaps in the primary health care implementation in West Pokot County. That's why we are calling our partners that as we journey together, we recognize that there are gaps there. We wanted to see how are we going to fill that gap. Some opportunities we can be able to address with you. So to see that as West Pokot County, operational the act and be able to realize its for health and well-being closer to the community. And whatever you may be able to access our budget, our budgetary allocation for the Department of Health, you may realize that we might be 10 billion. But out of the 2.8 billion, we are even unable to provide infrastructure to our facilities in the county. Reason being, out of the 2.2 billion, 1.4 billion goes to salaries. Another 400, which is little amount, 400,000, which is little amount, go to drugs. And even those allocation, we are not in a position to run our facilities for supply of drugs and commodities to those facilities. That will amount to 1.6 billion. So as a Department of Health, I wanted to say that if not our partners, especially on human resource for health strengthening, in terms of funding some of our activities, in terms of intervening in other programs, we could not be able to make it. But I wanted to appreciate His Excellency the Governor, because if you go through our budget, because it is in the website, Department of Health is allocated huge amount, but still from work we forward to the Treasury to give us sometimes with detail. because other department can have 10 million or 5 million for infrastructure or for development. For this financial year alone, and let me say this, because having had the presentation you made and some of the program you fund in our county, I want to let you know that for this financial year 2024-2025, as Department of Health, we have only one item for development. Reason being that more money will go on human resource and on drugs. So we call upon our partners for your support as we continue to partner together. So I don't want to make a lot of remarks, but allowed me to end there. And for those who give remarks, I want to say thank you for coming. Thank you for what you are doing in West Pokot County. We appreciate, we recognize, and we cherish. Thank you so much. Through consultation, I was to leave the county secretary to await the other thing before he gives his remarks. Nakubaliana na mimi. Thank you so much. Wacha ngojea wengine ili wakitoa remarks zao pamoja. Thank you so much.
Thank you, Waziri. Makofi tafadhali. Yes, we are now going straight to the agenda of today, and I'm going to hand the mic to take over from there. Thank you.
Yes, as they try to set up, I think the introduction session they had a secondary objective, which was for me to lose 2 kilos by end of tomorrow. So I don't know whether we'll achieve the objective, but the CDH guarantees that we can keep at it. So if I pass near you and find a panting, please feel free to stand and offer me. But I think we need to stand up and appreciate that very beautiful session as we set up. Kisema bunge. Bunge wanapiga makofi kwa njia gani? So bunge, baraza, bunge, baraza, bunge, baraza, bunge, baraza, 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 bunge. Now we've gotten the hang of it. Now we can start. That was a warm-up. So sugua mkono kabisa, sugua mkono kabisa. Baraza, 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 bunge, 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 baraza, baraza, bunge, bunge. So thank you very much. I think we now know each other much more, and therefore we can now be able to interact even informally. We want to now get into the gist as alluded to by the CDH on matters PHC. And we know Dr. Salim is also waiting to make his presentation concerning the national updates for the same. But to set the ball rolling, because we are, I think we can only take one presentation before lunch. I don't know whether the time is adequate, but I think Charles can come and be able to take us through that session. And we see how far we can cover, how much we can cover in the time available. So, karibu sana Dr. Itegi.
Thank you, thank you. As you have seen, my name is Dr. Charles Itegi, and I think this is an unfair position to be in. I'm standing between you and land. And then also, but the beauty about it is that even though I'm standing between you and land, I'm having the easiest task. Just because from what I've been hearing, most of us already know what PhD is. But now the only thing that I want us to learn about, where are we choosing THC as a way to go? I think we have the COG who have said this is a very good thing, but what exactly is THC? So that's where we are going to start, and then we move from there. Is that okay? So I usually think about THC as a very African way of doing things, in terms of in most of the African countries, or the most of the African communities, they used to live in villages. There used to be one medicine man to take care of the health of that village. So I think we're actually going back to where we started, in terms of we are actually empowering one person within the village to take care of the health of the people. And that one person who we are starting with is why we are taking the CHP approach. The CHPs at the back, those are the people who will be taking care of the villages and everyone who's living within them. And as our chief officer has said, for us as West Pokot, we still do a bit of the village. And for there, I think this is the best approach for us. Wherein, if you can have one person who has been taught about the basic approach to health, and then after that, they are taught how to refer the patient. I think those people living with them would be very, very lucky. And not only will they be very lucky, but they will benefit a lot from it. So, according to WHO, the main reasons why we do THC is, one, there is a lot of unequal access to disease prevention and cure and care in most of the developing countries. Because of this, we are trying to find a way to get everyone to access that. And then also, we also have what we call fragmentation of healthcare. This means that one dispensary is not connected to the referral centers. That is why we are looking for a network, a way with which we can be able to connect everyone. And then we all know, if you get sick in Kenya currently, you will actually go bankrupt. It doesn't matter how rich you are. The cost of care currently is extremely expensive. And then we are trying to increase the efficiency in the healthcare system. And we are emphasizing in the need to have someone at the community level who can take care of everyone. So now, today, this is a celebration of a long journey. This is a journey we started about 2 years back. We didn't know how we are going to start, but here we are. We are here celebrating, saying that we have 5 PCNs which are established. We are remaining with only one. And for those ones who have established a PCN, they will know the amount of work which is required just to establish one. And not only establish one, but change the mindset of the people. The other thing, actually for me, the things that I'm going to look at is why we did PCNs, what went into it. Of course, why we did it was West Pokot County. And the people who did it, we used the CHMP, the sub-county HMPs. We had help from the partners. We had help from the different members of the community. Now, because as partners, at the end of the day, you're using your money. The other question I'm sure every one of us has is PHC, because we are starting, is it beneficial to anyone? Is it worth the money we are investing? Is it something that we can do? And we usually say, if at all you can learn from others who have done it successfully, then at least that is evidence enough to know that this will actually work. Is that so? So now, back in 2015, now that Dr. Ndege is back, he's saying that in West Pokot, we are one of the leading counties with vertical transmission of HIV from the mothers to the newborn baby. So in 2015, there was a country which said that, which WHO said, as of today, they have zero transmission of HIV from the mothers to the unborn child. But then, let me explain how significant this is. When you come to viral diseases, unlike bacterial diseases that we have antibiotics which can cure them, for viral diseases, up to now, we do not cure viral disease. In that, the only thing that we do, even when you have a common cold, we only manage your symptoms. We do not cure the common cold. We manage your symptoms, we wait for the body to suppress it. So now, if someone says that they can make sure that the body suppresses HIV to the point of not transmitting to a child, it is quite significant. It is something, as in, if you think about it in Kenya, it's almost impossible. But then I was very curious about what have they done and how can they do that. I'll use even the other example for COVID. COVID is a viral disease, right? But the same country which had zero mother-child transmission in 2015, in 2021, right in the heart of COVID, they were also the first country to say, we do not have any new COVID case. So now, because this may be a story, I think we usually talk with numbers. That country is the one which has this hospital. This hospital, now when you go to their capital, the government has invested in the biggest, tallest building in the capital to be a hospital, a specialist hospital. But then again, let's look at the figures. The country I was talking about is Cuba. When you look at the figures, at the end of the day, as partners, I think at the end of the day, the most important thing for you is indicators, right? And the most important indicator for any health system is usually maternal mortality and infant mortality. Because what this usually shows is that how do you take care of a healthy person? When they come to you, they are not sick. This is a healthy person who has come to you, and now that they have come to you, how will you take care of them? Not when they are sick. How do you take care of them when they are healthy? So now, when you look at it, the maternal mortality for Kenya is about 362, and that of Cuba is 36. The infant mortality is 33.4 for Kenya, and for Cuba, it's 4. I went there for my master's for 3 years. We were a group of about 50 people, and one of the things that I can actually say, we were 50 of us in 50 different clinics, 50 different places within the capital. And for 3 years, none of us saw one infant mortality. None of us saw one maternal mortality for 3 years. Those are some of the things that I usually say. You know, in Kenya, if I go like no even to a ward, one weekend, if it goes without one infant mortality, It's a big thing, you know, 1 weekend. But now you can imagine 3 years without even a single child being lost. But then again, you also say, look at the life expectancy. The life expectancy for them, for the male is about 75, for the female is about 80. For Kenya, we are talking about 3.7. But then also the other thing you'll come to appreciate is the number of doctors they have. For every 100 people, 121, they have a doctor. Our ratios are much, much higher than this. We are actually at about 1:10,000 currently. We are saying between 10,000 and 30,000 per doctor. And then, but of course, they have the advantage of being a community state. But even then, the health system that you're moving towards is the social health insurance, which is more of communism. But then now look at it, immunization. Immunization usually shows this is just how do you prevent. For them, the immunization is about 98%. In fact, for them, it's usually almost 100%. Wherein everyone, for every 100 people, you have a doctor. So that doctor is charged to make sure every single person gets immunized. And then, of course, for them, all their hospitals are public, and then they have dispensary. You remember what I was telling you? These are some of the milestones they have been able to achieve through primary health. They eliminated malaria in 1995. They eliminated the vertical HIV transmission in 2015. They eliminated polio in 1962, diphtheria in 1939, measles in 1993. But you can see all the way. You remember there are studies everyone has polio. We can actually eradicate. Look at diphtheria. All of these, be it your measles, be it your mumps, we have vaccines for them. That means if we can be able to prevent them, we can actually eliminate them. And that is where we are coming in as primary health. We are saying the road ahead is good. And if you can look at the pamphlets we have small vaccines in bulk there, which are saying some of the benefits we can get from doing this right. So now, for some of the tenets of primary health care, we manage your diseases before you get very sick. At the end of the day, it is much cheaper to manage someone who just got a fever for the last 24 hours compared to someone who has a full-blown disease at any point. And then the other thing we are doing is that if you're coming to your house, we want to make sure the care is person-centered, and then we want to have a comprehensive approach to diseases, and then we want to make sure that not only do you get the right care at the right time, it will be done in the right way. And then even the other thing we are looking at is for the problems that the communities have, the solutions will be from the same community. That's why we are saying a community-oriented approach. So now, I think we have had this so many times, and we continue to hear it, but we still we shall still go on saying them. The determinants of health services, it has to be accessible, it has to be universal, it has to be comprehensive, it has to offer quality care, it has to have a primary care approach at the household level, there has to be integration across all sectors, from the social, environmental, and that same integration is why we are bringing in everyone who's playing a role in health, come together through this program. can cooperate and work together. And of course, health promotion is let us talk to people before they are sick. Let us talk to them about their diet. Let us talk to them about sleeping patterns and also what you do in your free time. And that is why we have the non-medical determinants of health. That is the kind of education you're getting, the houses you're living in, whether you are getting clean air, whether you're getting clean water. That's why we have wash with us, we have nutrition with us, and whether you're employed. Other social determinants of health will be your income. That is why I had WFP talking about helping the farmers get a source of income by partnering them with schools, and then the social structure inequality, addressing that, and other issues. So now, this is just, you are allowed, now we'll be having referrals to the dispensaries, to the to the health centers, and even all the way to the level 4. And these are some of the things that you'll come to see. So now, the goals of PHC, one is to eliminate the communicable diseases. What we are saying is, if something has a cure, you can be able to eliminate it. See, that's an easy approach to it. If you can cure it, you can be able to eliminate it. And then we are supposed to halt the rising burden of non-communicable diseases. As you know, this is the next frontier in terms of, this is where we're having problems currently. That's your diabetes, your hypertension. We are trying to halt that rise. And then also the other thing which we have been talking about is a mental disorder and any other mental disease. It's on the rise, and that's some of the things we are supposed to address. We're also supposed to reduce the violence and injuries, and of course, provide essential health care. This includes the ANC, your nutrition at the household level. And then we minimize the exposure to health risk factors. And also, and I've been saying this, and the reason we are here is the intersectoral collaboration. That's why we have brought everyone here, so that we start that journey together and we work together. So this was just an example of some of the things that they had in Cuba. That was one just showing health promotion. The same thing that we have with community outreaches, the mother-to-mother groups, that is just an example. So at the end, I'll finish with it. What can we do different now that we are here? The main thing that I'd like us all to do different is embrace the IT. It's a powerful tool. It allows for household registration of everyone, and then after that, it helps in assessment of the population. And once you have assessed the population, you can profile the population according to the disease risk. The profiling is this, the healthy individual. After the healthy individual is the individual with health risk. That will be your 2. The third one is anyone who is already sick. And then the fourth one will be someone who requires palliation and rehabilitation. And these are some of the things that you can be able to do with EACHIS. And with EACHIS, it actually gives the CHPs not only the immediate care at that time, but it will also help them. Once they refer, the referral goes with to the right person. And even by the time they are getting to the right person, they are able to go with the notes that the CHP has taken. The other thing we are talking about is HRH. I don't think we can emphasize that enough. Let everyone have the right information about their health, so that even when we are talking about health, let everyone be able to take responsibility and be able to do the right thing when it comes to health. And of course, with all this data being available, let us use it for research so that we can get solutions for our health needs. So of course, we are prioritizing the primary healthcare as opposed to secondary healthcare. And then we are profiling our population, and we are restructuring our primary healthcare in terms of primary care networks. And then we're focusing on the priority groups. That's your mothers who are pregnant, and then your newborns, the communicable diseases, your elderly population, and emergency care. We are going to strengthen the community health systems, and then we are going to go to the multi-sectoral involvement in everything that we are going to do. And then we're increasing capacity for everyone. And then finally, asanteni sana. And I think I haven't taken too much time. I think it's like
Usigue mkono, weka kilo, ongeza, tuna abstain moja. I think we need to set a food. And that's why Daktari say as a strategy, we need to combine all strategies. Usigue tena. Let's see if we can abstain. They say it's very hard. Haya, ongeza kilo, ongeza, weka. Yeah. I think that is within the range of normal distribution. So I just want to invite us to look at the theme for this particular meeting, and to just tie in with what Charles had actually taken us through, and the various presentations by the various partners, and the objectives which our CEC ably outlined concerning this particular stage. So the question we are asking usually, and I think Peter actually talked about it, about the issues of proposals. Usually when partners are coming into a place, they have done a proposal, they have applied for certain grants, they have gotten grants, they have key result areas, they have key performance indicators that they are prioritizing, and they have layers of people who are tracking those KPIs. And it so happens that some of the grants are 5-year grants, 3-year grants, multi-year grants. So how do you align with a government that is saying that this is now the direction we are going, and it's pronouncing itself in terms of legislative action? And they are developing a primary healthcare act. And they are saying, we are reorganizing our health administrative region. Now you are a partner. You have a grant, and some of them are called fixed. They are not corporate awards. I'm sure corporate awards are better, with a bit of flexibility. So that is the kind of thinking we are now asking ourselves. How are you able now to plug into this new policy environment? Do you stick to your grants and say, these are my KPIs? This PCN business is new, because what we are basically going to discuss, and the sharing of the findings of the baseline assessment, is purely structural. So how do you align? Do we need an extraordinary forum with donor agencies and the budget holders for us to be able to discuss and say, look, this is our reality. We are saying our initial health administrative region was the sub-county, manned by the sub-county health management. Now we are saying that we now have a primary care network as our new health administrative region. And we are even saying that this new health administrative region will be manned by a primary care network committee, a new institution of leadership and governance, which Waziri here will be shortly gazetting together with the mapped PCN. So now there we now need to agree and discuss as partners. What are the options? What is realistic? What is realistic? Because sometimes tunakimbia kwa Mercy as SDF. Kimbia Mercy. Hey, you are doing so well. Eh? Dr. Ndege, you are doing so well. But this is our priority. How can you plan? I'm looking at my budget. I'm looking at my budget, not seeing. Okay? We rush to Big Brother. And I say, okay, I hear you. I'll give you, but up to this day. Okay? So then we go back. Mercy is very clear in her head that her county programs are limited to certain KPIs and KPIs. Yeah? Na sisi tukikaa the PhD level, which is prostating and so on as the HMC, we feel those are still very narrow, and we have a platform which we even want to do. So for instance, one of the biggest gaps that is going to come out is that we have 650. This one I think I need to with 650 community health promoters who've not undergone promotion training. Even illegal training. And there are key indicators for community unit. And one of them is that training before we look at the other. Now I have Professor Sam who comes and says he's going to help us carry the issue of elimination. And we are saying there is this particular problem. But we also know Sam is also has a very global and bigger reach, and he's working on molecules, trying to convince the world that these molecules, yes, are very critical and they actually work. And in that regard, by bringing research to treatment, he's trying to push the agenda forward for elimination. But as we are now saying, Prof, we have a structure here called how do you plug it? Now, luckily, because you're strong on research, something happens in Ethiopia and we end up getting funding to do a certain research here. The security situation ni ngumu. Nasikia program officers are implementing from the UK. So now the budget holders say, wait, our brother Kenya here is relatively safe. We have history of working in them in multi-site research projects. They have 2 treatment sites. Can we deploy? Enter Dr. Kosire. She now comes and tells us, your location of the treatment site in Kachelipa, while being very good, and it has really served us well, it seems our caseload from this nomadic population is where? Is better served from Sikor. Now, Professor Sam and all those other people are looking at their monies and they say, okay, they had money for infrastructure. We need inpatient facilities and so on and so forth. And before we know it, we have a modern inpatient facility. But here, Saraku here again is standing and say, look, the overall objective is elimination. And we must intervene at the house. Rose anakuja with eye care. Anasema, we want to be able to screen the population at the household level as CHPs. Now we start calling them, is it case finders? Gladys. We train them on how to identify trachoma. Okay? And indeed, the numbers after the exercise are mind-boggling. Therefore, they are plugging into that. Now we look for success. Now, beyond that survey that you did, that screening session, how do we sustain this on a day-to-day? That brings us an all partnership to the high impact interventions at community level. What are they? And I put it to you that these are things which we need to revisit when we are designing grants, when we are looking to award IPs on grants. To me, I'm advocating that we align the grants to the key interventions in primary health. That yes, you're doing nutrition, but we know we have CBFCI. Will we now target CBFCI alone? We're interested also in dealing with basic mode. Yes, so that we build the capacity of the CHP to scale, to even other programs, so that we have, beyond the life of the project we have it affecting and spilling into other areas and improving the life. So that is what we are talking about, routine programming and primary care networks. What are we really saying? That we need to rework it. So far, in terms of management of the kind of programs we are having, there is understandably some vertical programming. So we are saying, at what point can we have that conversation? Is it at high level, donor level, at IP level? As government, what can we do? Because now we are talking about routine programming. What we are going to share is reported speech. And yesterday we were laughing, it could be lamentation, about the weaknesses here, weaknesses there. But here we are also celebrating our partnerships and saying, yes, under very difficult conditions, there has been goodwill from the county government. And we've seen a steady, slow but sure improvement in, and we shall be seeing some of the investments that the county has made and those that the partners have made. And the gallery walk will augment that conversation. Because here, as Waziri had said, we are celebrating our partnerships. And at some point, we look at these commitments. How can we tinker them to make them mean something more in terms of routine programs? And that is the theme that we are having, that we are embracing PCNs in routine programming. So when we look at programs, at face value, we should be able to say that this is truly aligning. It's aligning. So I want to stop there, and I just want us to appreciate the speakers that are there. I want to invite, let me move closer to our pastor to pray for lunch. How much time are we taking? Because the national level is waiting to make a presentation on the updates on PHC. Do we attempt 45 minutes or 50? Sorry, it's now? It's one what? Sorry? So when do we come back? 2:15? We'll be seated? We promise we'll make it brief and sweet. Okay? When we come back. So can we rise up? We ask Dina to pray for what is before us, and we keep that. Thank you very much.
Tuombe kwa ajili ya chakula. Baba wetu, tunashukuru ni kwa ajili ya kutupa kuzana chakula mtakatifu, tunamshukuru kazi ile na kutupa kwa ajili ya Kristo and
Daktari, are we ready? I can hear you.
Can you see my presentation?
We can see your presentation, Daktari.
And hopefully it is in presentation mode.
No, you can put it in SlideShare from your end. And you can increase your volume as well. That would be great, Daktari. Daktari, are you ready? I think we are there. You have the mic, Daktari.
Can I
Please
proceed?
proceed. Please proceed.
progress.
Daktari, can I proceed?
Please proceed, Daktari.
Hello, good afternoon. Can you hear me?
We can hear you, Daktari.
We can hear you. Kindly proceed with this. The mode for us actually to get to UHC. So why do we pick PHC? One, this is a high impact investment in PHC. It provides high quality and low cost of care, which is cost effective for the people. It also brings about equitable distribution of health, especially in the areas where the building blocks are low. It also serves as an early warning system to detect and stop diseases before they become epidemic and preempt epidemics before. Then PHC empowers individuals, families, and communities, and this also improves health access to families, communities, and most importantly, the individual. Then this is one of the ways that we improve health access to more appropriate areas of services. This is one of the ways that we actually implement the TEF and the cohort system so that we can have a continuum of care. We know that PHC started long time ago after the Alma Ata, where we actually were part of the declaration. More importantly, it was looking at bringing PHC to the developing countries. There were about 134 countries that participated, including Kenya. More importantly, during this time, we know that we were given PHC to implement, but the how was the main issue, where as Kenya we came up with the primary healthcare network. With Alma Ata, we know that there was reloading of primary health care, where more importantly, the issue of multi-sectoral approach, that is health in all policy approach, was emphasized. Empowering of individuals, families, and communities where our community health services comes in. And then more importantly, the issue of having integrated comprehensive health services, especially looking at avoiding medicalization, but also because of the reduction of finances, especially the donor to our programs. As TANA 2023, more importantly, they were looking at what are the progress that were made since the ALMA of assistant community health promoters who are working in the PHC space. We have several documents, including the constitution, look more importantly in the implementation of UHC. We have several documents of a community health unit and a community assistant for each community health unit. We have a scheme of service for the community health services personnel. We know we have to align because of the dwindling funds to the transition policy where the government needs to put in more funds. Down at home, we have the Kenya Primary Healthcare Strategic Framework that we use to implement the PHC, the Primary Healthcare Network Guidelines that we use to establish and operationalize our primary healthcare network. We have an intersectoral document that was supported by the WHO to implement the multi-sectoral actions and intervention. We have several documents that support us in social accountability, empowering the people to hold us accountable, including the advocacy communication and the community engagement for primary healthcare, and also the community scorecard document. We have other documents that support the community health workforce, including the community health volunteers training certification and the curriculum for the community health committees. When we're talking about the PCN, basically we are looking at the hub, which is level 4, and the spoke, which are level 3, 2, and the community health unit. We use the primary healthcare network guidelines to establish these networks. Administratively and technically, we have a multidisciplinary team to support the spoke, that is level 2, level 3, and the community health unit by providing services, especially inreaches and outreaches. We have a management leadership and a governance body called the Primary Healthcare Network Committee, including the sub-county health management team, the private sector, state-based partners, community health committee, and the multidisciplinary team member. When we are looking at the sensitization or training on PCN, there are several areas that we look at. One, looking at the SDGs, PHC as a global agenda, the government plan, that is the bottom economic transformation agenda, the UHC national policies. Then when we're looking at financing, we look at different financing mechanisms. We are glad that the FIF was passed. We are moving to share, and we want to reduce the out-of-pocket. So under primary healthcare updates, especially looking at our documents, we go through the primary healthcare network. Under community space and health promotion, we look at the community health and health promotion documents and policy documents. Then we also tell the counties to take us through how they're implementing PHC at that time. Then we do a PHC assessment to give us the baseline. Then we are intending to digitalize to next month all our PCN, and then we put a monitoring, evaluation, and accountability learning process. When we are talking about decentralization, there are about 11 steps, including stakeholder sensitization. Dissemination of the baseline assessment. We also map the hubs to the community, to the spokes, and then we also map the households, and including registration by the community health promoters. We identify which will be the financing mechanism.
Recording stopped.
primary healthcare network that are yet to start.
Recording in progress.
Dr. Simon, we can't hear you.
So when we are looking at the patient, we look at them as enablers so that they can support in provision of integrated services, should be people-centered, provide timely services of high quality, bring about equity, safety, efficiency, and effectiveness. We believe that the patient will enable to integrate and make different institutions work together, including the health workers, the different disciplines, the different health levels, the programs will work together, the sectors, that the community will be given a priority to give a chance for engagement. And then we're looking at primary health care as important for primary health provision. So some of the expected outcomes: reduced workload at child facilities, especially if the community health promoters and MDT teams and interventions work. Clients identification, who didn't know they have diseases through screening, like hypertension and diabetes. Integration of various programs to PHC, the increased advocacy for increased investment, especially in the primary healthcare space. There'll be improved referral system. It will be patient-centered, not disease-centered. There'll be improved and a lot of the data collection and utilization to make appropriate policy and intervention. So some of the achievements we had from now, we have trained 248 primary healthcare network master trainers. We have 190 PCNs. We are increasing the functionality of the PCNs that we have made, looking at the functionality criteria that we have, improvement of referral system, especially for health care services and the diseases that have been screened, improved services coverage, especially with the in-reaches and the outreaches, including programs like immunization. There is enhanced collaboration within programs, within health cadres, within the different sectors, and that we believe that this will reduce the workload in the different higher levels. This will also bring a patient-centered health provision and health level. It will reduce silo and vertical programming. There will be more improved data utilization, better knowledge management, and on-job training. Then continued progress and innovation, which we have seen in different areas through the PCNs, including some counties passing the FIA bills, gazettement of the PCNs, areas like Kisumu where they have drone distribution. They have included a faith-based in their PCNs and these integrated and comprehensive services. Areas like Kwale, they're using a portable obstetric ultrasound. There are MDTs that are visiting clients here at the household level, including Nairobi and the Lamu. Increased fully immunized coverage. Areas like Garissa, improved infrastructure and polarization of the main referral system, including areas like Kachalibna, and then enhanced understanding of population profile, where the PCNs take care of a particular number of people, 150,000, increase facility-based outreaches, including areas like Garissa, and then there is more advocacy for increasing investment in the primary healthcare facilities in areas like Luanda and Mahaya. When we're looking at operationalization, this is making the PCN able to function. We looked at several criteria, including the hub identification, the scope identification, the community health units working, household registration, having a functional MDT that team members have been identified and have their specific role, having a lead of the MDT. We gazette the PCN. There is a coordinator for the PCN who is the sub-county MOH. There is a coordinated referral system. MDT at least organize monthly community outreach activities. Then there is specialist MOH visits from level 4 to the lower facilities, which are the spokes. And then this leads to operationalization of the PCN, which will include the actual service provision. So when we're looking at operationalization, it's very important that it is planned as a program. Programs go together, integrated and comprehensive. Issues of the building blocks, including human resource, are looked up and addressed if possible. Financing, infrastructure, ICT. Then in some areas, especially in the PCNs, the network, there will be need of sharing of non-health sectors, staff like the accountant, the procurement, so that they can be able to function, reorient the leadership management and the governance. For example, having the advisory committees, the MDTs, then planning for preventive and promotive activities, which most of the time were not being done, especially the screening that has already been started by the CHPs. Then, of course, for us to have sustainability, we have to look at the PHC as an important agenda, especially as the government has done so. Then these PHC activities need to be put in the annual plan. In the long run, also, they have to be in the county integrated development plans. We have to mainstream PHC. The operationalization of the several acts, including the social health insurance, digital health, facility improvement financing, and PHC will support in the implementation and funding of PHC activity, making the PCN smart so that we can have sharing of records, telemedicine, we can have a referral system. And then it will be good for the FIF, for the counties to put aside a percentage of this money to actually to fund PHC. Then, of course, if any other sources are available, they can be used, and having different innovation so that we do things differently to give services and increase the coverage. Some of the challenges we're still facing is people operating the PCN as vertical projects and looking at them as just the outreaches. Then most of the building blocks for a long time, there have been gaps, including the human resource for health. The MDTs requires planning and streaming and logistical support resources to move. There is no particular framework to engage other than health sectors as we're expecting. Then currently, the CHPs are increasing a lot of demand. Sometimes the supply is not proportional to the same. There are challenges in handling the PCN as a unit because now we have brought together several entities. Then sometimes the outreaches, when we talk about outreaches, people just think of going out, not even giving services, for example, in the same facility. Then we're still a long way in operationalization of making the PCN smart. Santen San.
Thank you, Daktari. Thank you, Daktari. Can you hear me? I just want to invite questions before we release him. Do we have any particular questions that you want him to address? Ross, you have something?
Thank you very much, Daktari, for that presentation. I just wondered, one of those who are referred get to the facilities and don't find the services they are looking for, then perhaps it makes it more difficult next time to even try to access those facilities. So I'm just wondering what maybe is being done to be able to access the facilities. And I also know sometimes some of the challenges, and I'm thinking in this case, for example, like West Pokot, a very vast county, the distance that the patient has to travel to access that nearest facility. And sometimes maybe they might not have even the means of transportation to get there. I don't know what, if there is anything that can be done to try and solve those two problems or issues.
Thank you, Rose.
Can I proceed? Can I proceed?
Please proceed, Dr.
I think in terms of increasing the demand and then the supply is not enough. But some of the things that the government already has done is done two major assessment. One for facility assessment, and the other one is the quality of health services being given. I think this has given us an idea what are really the gaps, and where it's possible, I think the national level with the counties, with the partners should try and address this gap. Where it is not possible, I think one of the things we can do is look at this multidisciplinary team, make them very specific to address some of the urgent priorities that are in those areas, and even move down from just a sub-county, but actually deal, for example, having teams to deal with the ward level or even lower. I think that goes together with the question that you have asked me in terms of the provision of services, and if we cannot get there. More importantly, I think the MTP can actually be customized. The hubs where we have very large, vast areas. For example, in Garissa, what they have done, and even Turkana, what they have done, they have come up with what they're calling mini hub in the health center, the level 3, so that people do not necessarily need either to be referred very far. And the NDTs are actually also brought down to a lower level, that the level 3 team actually now give services to the other level 3 and level 2, so that they can actually deal with the issue of the distance and the resources moving, because we know that could be a cost. So some of the things people have done is have mini hubs. The other thing is even in the level 4, they'll have either the outpatient area or specialized care, where we can also have primary healthcare services, so that either the people who are surrounding there can still get services instead of referring them to very far. So I think one of the things is actually now even rolling down the NGTs to be formed at level 3 instead of level 4, so that's to cover the distance and to avoid the referral in vast areas. Back to you.
Thank you, Dr. Let us take another one.
Thank you. Hello, Dr. My name is Stella from UNICEF. You mentioned the successes, obviously, that have been achieved in the legislative space by, enactment of the bill. Now, the Primary Healthcare Act is actually supposed to provide for how financing happens at the primary healthcare level. And also the shift provides for how financing happens at the hub level onwards. So my request to you is if you could expound on how that works out, a little bit on that, so that we have a very clear understanding of how financing for this particular sector should happen. Given that you highlighted that the MDTs
have challenges as regarding how they move and how they finance their plan. If you could highlight that, would appreciate. And the second one is a comment. I have seen in your presentation that you've given examples of counties that have made progress, but I realize that could be that West Pokot don't speak a lot about their achievements, because this was the first county to enact the FIF Act in 2018, I think, 2019 there. And it was the third county to pass the Community Health Act. And you know, it's good to praise someone. So maybe while you edit your presentations, you could also include us up there and you tell other counties, you know, like West Pokot have been able to do this. Thank you.
Salim, will you take a rejoinder from Ross? Okay, fine. Please proceed, Dr.
I've been requesting counties, especially the county primary health coordinators, to give me their best practices and innovation. Unfortunately, the ones I've put, the ones I've got. This is almost the fourth month. I've been asking, I've been telling them it's good for me to know and also to share in other forums. So this one goes back to the county people that they should share with me so that they can share with others. The other question is about financing. I think we need to start from the position that primary healthcare actually is not new. It's not another project. It's already going on. What the PCN is doing is actually give it a more better coordination, more efficiency, effectiveness. But of course, it needs some resources. But I think we can start where it is not cost intensive. For example, the images that we are talking about before people go out. What is it that the MDP is doing for even before the client? What is it doing for the health workers? Do they have plans for them? Do they have screening for them? Even the individuals, us as health workers, we know in a year what we should screen. Can we explain to our colleagues, our family members, what balanced diet now means? Is it still the 3 food types, or is it the 10, and how many is that? Issues of exercising. So I think we need to start with what is possible. For example, in Lamu and in Nairobi, when they're going out, the MOH or the health workers are told actually to go to the households that are next to them, so that you don't need the resource. I'm not saying we should not plan for the resources, but I'm saying we can start with what is less cost intensive so that we can move, and also already right on the programs that are already there, the immunization, the reproductive health. We know all the communicable diseases have a component of prevention and preventive. How are we riding on this? Then we can look now at getting further financing, especially in the implementation of the other act. Back to you.
Thank you, Daktari. I'm being reminded that the nutritionists are saying it's not balanced diet, it's dietary diversity. But I'm told it is with the pan. Okay, any more questions for Daktari before we release him? Can we release Daktari? So thank you very much, Daktari, for making time. We know you are on a very different assignment and you agreed to make time for us. We really feel appreciated. I think we'll be able to work on some of the sentiments that you've given as we move forward. So thank you very much. Over to you.
So thank you yet again for making time to be with us again. For the evening session, we'd like to start with, I told you it's a 2-year journey and we are still going on. So from that 2-year journey, there is so much we have learned, there is so much we have done. And now in the process of the establishment of the PCN, one of the things that we did was look at where we are. By looking at where we are, you do a baseline assessment of the health facilities, of the community units, You look at what the clients are saying about the health facilities, what they are saying about the hospitals, and then all of that. From that, we got about 400 pages of documentation. We have been systematically reducing it. And for today, all you're going to do is give you an overview. For starters, we've already given you an overview, which is part of your program. I think it is from page 3 all the way to page 3, 4, 5, up to page 6 of your program. That one covers all the sub-counties which were done for baseline assessment. But even then, as much as you have that, I will let Dr. Murie take us through the key highlights that were gotten so that now you can understand where you're coming from. Is that okay?
So thank you very much. So as Dr. has mentioned, whatever we managed to gather was quite voluminous, and we are still working on teasing out the key recommendations, and some are captured with you. So my singular duty really is to rush us through this so that we can be able to just appreciate where we are as a county. And we've tried to even summarize what you have here because the methodology was much similar across the sub-counties for conducting the baseline assessment. It was done by the sub-county health management team with technical assistance from the CHMT and partners. And basically, there were several methods that were employed. There were client exit interviews which were conducted using approved tools by WHO, which I think we've customized as a country. We also had questionnaires, again, which we were administering to the managers in the facilities. And we had focused group discussions targeting the adolescents and young people, pregnant and lactating women, and so on. So we have a mountain of data, and we were trying basically to be able to analyze this and be able to summarize this in a manner that can affect implementation going forward. Next. So I want us to look at the program that we are having. Basically, you will realize that the findings, next, the findings are organized in terms of the health system investment areas. And in terms of leadership and governance, basically here, what came out clearly and is information that we had is that basically what we've managed to do as a county is select the majority of the health facility management committees, but we are yet to train them. That is a massive gap. There is usually a 5-day training that they need to undergo. So, yeah, so it is a gap that we are requesting that we probably require some partnership. We have close to 200 facilities. So if you are doing 9 health facility members and you're taking them through a 5-day training, it's quite capital intensive. In the past, what we've done, and we've done with support from AMREF, was to train the Secretary for the Health Facility Management Committees. And it's very critical because right now we are saying, with the passage of the FIF Act, all those who are in management, including that organ that takes care of the affairs of the facility, must know that they need to support the linkages with the community level, and that there are linked facilities which are there. And that really brings me to the next question. And one of the findings, when you look, the highlights of the findings, when you look at the structures of governance for the community health committees, you will realize that if you look at all the sub-counties, there was consensus there are no functional community health committees across all the sub-counties. And the innovation that the CHMT and the other managers are really considering with the leadership of the department is that to enhance linkage between the facilities and the community units, we have that health facility management committee inducted to act as the community health committees as well. Because if you look at their selection processes and their compositions, they're almost the same. So that came out quite in a big way. And as I said again, those are the numbers. So we have an opportunity here to address leadership and governance for all our our spokes, or level 2, 3s, and CUs, by targeting this particular team of HFMC. So as we induct them to do their roles as health facility management committees, we also equip them to perform the role of community health committees with add-ons and so on and so forth, to be able to effectively discharge their mandate. So the other components which came out quite significantly when you look at the feedback we received. In terms of grievance redress mechanism, there is a lot of work that we need to do, and this is tied to social accountability. Our mechanisms within the facility were not up to scratch in terms of being able to elicit. We do not routinely conduct the client exit surveys. We do not, in a structured manner, use the suggestion boxes. And we've had several discussions, and we are happy that some partners under the HSSS mechanisms are actually bringing up the issue of grievance redress mechanisms. And it is interesting, some of the ideas are coming that it's no longer sustainable for somebody to go put their comments in a suggestion box. Some are suggesting a QR code that you scan, some are suggesting SMSs, so that there's a bit of confidentiality with the kind of feedback that is being given. Others require that you'd have a piece of paper and a pen nearby, so that a patient can be able to give feedback. So those are some of the innovations around the issue of GRM, and we are happy that some programs are taking this up, but there is a lot of work, because this structure cuts across all our facilities, and it's something that we need to do. For example, they are supposed to have a register of the complaint and how we've solved them, meaning there needs to be a dedicated team that opens and records as is everything that is captured and closes those complaints. And those ones that they cannot, they escalate to the next level. So it is quite engaging to be able to do this, and it's something that we really hope we can continue strengthening our partnerships on. Then the issue of quality improvement and WITS is a work in progress. The structures are being set in place, and we are happy that this is going to be a reality soon with the formal appointment of the QITs across the sub-counties and their trainings. We are happy one of the USID mechanisms has actually all these USID mechanisms have the 3 sub-purposes of community health, human resources for health, and quality improvement. So we hope we can be able to work to strengthen this. But there was overwhelming feedback that this was clearly a gap in how we are operating. Then 64% reported that there is integration. So unfortunately, the methodology that was picking this was a questionnaire. Would have loved this to be in an FGD. So it is something we need to improve on, because when you triangulate it with the support supervision reports, you find that, yeah, the gap might be much bigger than this. So these are critical areas that we hope our partnerships can be able to address, but we are happy to report that the leadership was able to set up 2 new sub-county health management teams in the new gazetted sub-counties. I know we're moving to PCNs and so on, so we were struggling with 1 sub-county health management team covering the entire North Pokot. Now we are happy. The leadership has actually put in place the health management teams that are covering those areas. So there will be more contact time between the HMTs and the facilities, and that means the quality of oversight and mentorship is going to improve. So we are very happy about this. We are also looking forward, because we are in the process of rolling out the structures under PCN. We know that the gazettement of the PCN committees is going to happen, and this, make sure we are having in-reaches, outreaches, to be able to scale up the registration of our people in terms of them getting IDs and being able to participate fully in matters health. So there are many other issues, but we picked on these big challenges concerning the same. The other issue with health financing, of course, at facility level, when you compare some of our FBOs and the kind of rebates they are getting from NHIF, they have invested in the claims process. So this is a learning point for us, that we want our facilities to also improve this. And there are a lot of things happening. We are leveraging on ICT. We are scaling up connectivity so that we are more efficient, but certainly will require a lot of support to be able to reach all our facilities. In terms of human resources for health, you can see from whatever you have, most of our facilities, the primary healthcare facilities, were manned by very few staff. And we are happy that we are adopting the workload indicators of staffing needs. And this is being supported by Cheboy and team, and we are hoping Uzima can take up from that to take it to the facility level. So we have a challenge here, but as a department, we are happy that there is progress that is being made. I think there was phase 1 of promotions, which are important to give morale. Others are being lined up, and recruitment and retention has been an ongoing process. So there's a lot that the county is doing here with the support of the County Public Service Board, and we're happy to report that the staff indent has actually been finalized, I think, Chief, and we now know clearly what we need. But it's an area that is, and you remember in Waziri's address in the morning, of our budget, 1.4 billion goes where? To salaries. So in terms, if you look at our budget generally, it is not program-based. Because the traditional programs that we use for planning is general administration planning and support, curative, rehabilitative, and preventive promotion. But here we have EMTCT with a complete guideline, with interventions. We have HIV camp treatment with intervention. We have RH with intervention. We have disease surveillance with intervention. So one of the things that we continue to advocate is that we try to make our budgets more context specific, as we align with the broader organization of the budgets by finance and economic planning as we do more. And if you look at this now, you will see there is an attempt to allocate a little resources to certain programs. But we need to scale up that and accelerate that. So we are happy with the initial. We've managed to start talking about IRIS, the teams of data from manual registers to now the system is happening. We hope we can be able to conclude this. And I think we've had the first meetings for work council sensitizations last week, I think, supported by UMI. So we really are happy about this. So the critical gap that is relevant for our conversation today, I think it has been very well captured by our team from Community Health Services. the CHA CU ratio is quite a problem. The shortage is 169 community health assistants. We have many other problems, but we are saying the ratio here is a problem. Why? And the importance here is that we need to ensure that the data that we are being given by our colleagues CHPs is actually factual data. And one of the things that we've always struggled with in terms of quality assurance is how do we do community unit support supervision? Before, in the old tool, we used to use the one that the CHA was the respondent. Later, it evolved a little bit. We started sampling households to see what kind of services were offered. But from our partners here, Mercy will tell you it's very expensive to do community unit support supervision. So the idea here is it the only way we can do it? Do we have counties or programs, even partners who are doing it in a better way? This would be an area where we would be willing to learn. How can we make it sustainable? How can we make it routine? Because what you're going to have is data that is not reliable. You look at data when you triangulate with other indicators. They say household registration is at 70%, but contraceptive prevalence is stuck below 30. Fourth ANC is below 30. Immunization, we are just after 50. So it does not tell you the story. It means either you're dealing with fake data because the contact time there is inadequate. So this is an area which we really need to focus on and see how we can strengthen PHC. Because if we can, number one, right now we are struggling to ensure that CHPs are reaching the household. Now, as we push that agenda, we'll be looking at the quality of that household visit. What was captured? What did he cover? Did he carry the counseling cards that he is required to carry? Yes. Did he complete the household registration? Has he been doing defaulter tracing? And this is where Charles was saying it is now becomes a game changer. But we have to get these other fundamentals correct so for us to leverage on this particular platform. But these frontline healthcare workers will help us. So that when a CHP is giving data, we know this is credible data and somebody is not just working on numbers. Yeah, so again, that, and I said this one, we probably need to whisper that we still have almost 600 people not trained on EG. Okay? So hii ni kubwa sana, eh? And if Gladys here was to show us the database, it can prepare us stress. Sindio, Gladys? Yes, we are not doing very well. When you look at the workflow, I don't know whether Charles will have an opportunity to show us. The last, what can I say? What do you call it? On the end, the one on performance, it's very helpful. It can tell you exactly how you are doing. Yes, so this is a tool that we really need to deploy well, but we need to even complete this. And as we've said, this, if you complete each training to a CHP who has not been trained on the basic module, changamoto. And we start at a disadvantage, especially when we compare ourselves with, say, Vihiga, which is 100% ICCM trained. When you look at their dashboard, you look at ours, kidogo unasikia pressure inapanda. So as a county, we are also awaiting the rollout of what? The Kenya EMR. I think the initial sensitizations of the people to spearhead this has already happened from the county. So we hope we can be able to benefit from this by linking our community units to our facilities. And what Salim was talking about, the data being portable and available at whatever point of service delivery, then that will become a reality. Then, in terms of health infrastructure, there was a lot that was said, and you will see it in the thing. But what we are saying is that we are lucky that this approach that we are taking that has to have hubs that are at level 4 is actually captured in the flagship projects in our CIP. And therefore, us is just fidelity to our plans. But you remember what Waziri said. If you have 2.2 billion, you do what? You do 1.4. You do maybe 60 million maintenance of what? Fuel. Yes. You remain with maybe, if you are lucky, 100 million for development. Sigor alone requires about 179 million to get to level 4. So you can see we will take more than the years remaining in this term of government for us to achieve level 4 across all the proposals. That is really the starting point. And what is and really why we are prioritizing this investment into the PCN hub. When you read section 18 of the PHC Act, and what has been stated as we need to do is we need to allow the CHPs to register us. And the middle class, apparently, they have misgiving. Kujua hii mtu anachunguza sisi sana, anauliza hii. Sasa hata kufungua gate ni stress. Paka CHP semeni wewe, CHP wewe. Thank you. So tunawapea kazi ngumu sana. So we now need also advocacy on this importance of household registration and how it ties to all this. And for this we require support and partnership to be able to do this. And we are happy about the composition of the PHC advisory, which has some of the critical actors that can help us be able to drive that agenda. So, so in our setup, facilities at level 4 that now qualify to be PCN hubs, actually 2. But Kacheliba now is offering emergency cesarean sections and is just remaining with a few things to get to true level 4. Sigor now also is ready because the theater is done, the infrastructure is there, including what our colleagues from DNDI supported. If you look at the infrastructure, we're almost there. In Alale also there's a theater constructed. There's the issue of equipping, staffing, etc., etc. So our facilities that we identified are those ones that are very close, that we believe if we successfully implement our 2 ADPs without disruption and get support from equalization funds and willing partners. And yes, we've benefited from a lot of goodwill from partners. In fact, there is a mother-baby hospital complex that I'm seeing like it will be a reality in the next few years. We have theaters in Chepareria Sub-County Hospital, which we believe by next year, around this time, we should also be having positive news to report. So we hope that if we implement this, we can be able to move. But in phase 1, we are focusing on our hubs to get to level 4. Because if they use capitation and the registration to the hub, which is mandatory now as per the Act, then there are people who will have to pay out of pocket. And we want our people to get all the services they need that is essential to them within their PCN. So our priority is to ensure that our PCNs are at level 4. And all these have been captured in our CIDP 2023-2027 and the ADPs that Salim was referring to. Ni mimi ama ni nini? Okay. So in terms of HPTs, I think we didn't get to that. I don't know what happened to the slide. We are doing well. The only challenge we are facing is that the facilities at the border. Okay? Whereas the other facilities in the county, zinakaa 3 months as per our reorder cycle. This is a border hapa. I think our brothers from across, and in the spirit of UHC, I think the county is absorbing all those challenges. But we are hoping to increase with the increase of that, we hope in the ADP we planned for 300 million for HPT products. We believe this can be able to take care of us. And the biggest HPT that gives us sleepless nights is what Peter is sorting. We hope we can have a sustainable arrangement where the SFP commodities are actually handled. Because as it is currently, we do not have the capacity to be able to, I think it was 100 and something million annually for SFP. I don't know whether Eliza and CNC can confirm. So there was a number, but it is a funding gap. So we hope that WFP can be able to continue doing this thing, and one of the recommendations we are having, and I'm glad Peter is also aligned, that they are going to take us as one of their traditional counties for support, together with Turkana and the northeastern counties. I don't know whether Isiolo is also there, so that they can continue supporting us, and to be able to ensure that all the moderately malnourished children that we are working with are able to be taken care of going forward. So I want to stop there. I know that was an overview, a sneak view, preview of all that is there. In your free time, you can also look at what is in your attached to your program. So thank you very much. I may return. Okay. So do we have concerns based on your review of what we prepared? Yes, Susan.
Okay, thank you, Daktari, for that presentation. I just had two areas that maybe don't appear so clear to me. There's some literature that talks about a seventh pillar of the building block for health, which is community health. And usually, like, this is where everything comes converging, and, like, everybody then wants to utilize this platform to deliver services because of the way it promotes equity. So I know at the national level, they're talking of 14 packages. As a county, is there a minimum? Is there consensus on, the kind of packages that are going to be prioritized? Because, it may not be realistic for the CHPs to deliver all the 14 packages. So I don't know whether, if that hasn't been discussed, it's fine. I just wanted to hear that, whether this is something that you would consider as a county. And then my second question is on health financing. The feedback was more on NHIF, which was more around, covering the needs of the patient and, to some extent, the health system. Was there a component of donor funding that was looked into? Because, like, the health financing discussion usually covers, the whole spectrum, right from the patient needs being covered by financing the health system. And now also there are some of those gaps that are covered by donor funding. Are there some challenges? Are there some gaps in that space that maybe came out in the review? Thank you. In the baseline.
Thank you, Daktari. My question is, usually when questions are being asked, the respondents give answers to the questions that have been asked. Were these questions, when you are asking them, related to asking whether this is the major or this is the main issue in those specific areas? And again, were you looking at issues that are related to high impact interventions? Because there are so many things to be done, but the resources are limited. So if we can on the high impact,
with the limited resources that are available and depending on the questions that you are asking. That is my question. Thank you. And thank you for the findings that are going to inform a lot of processes in the county.
Thank you. Thank you, Dr. Muriye. This is Mary from SDF. My questions are two. One that my colleague from UNICEF Susan has asked in terms of, the quantification, and I want to believe that in the CIDP, also the math around the required funds would be there. But I would have loved to hear what I know you have brought out. What are the pressing, like what is very urgent? If you ask me, I think functionalizing the PCNs feels very, very primary and important and also urgent to you. So just the things would need to be done. Thank you.
So maybe could we cut those ones, address those ones first before we move? I think those are very interesting questions, but I must say that the assessment was not powered to provide certain answers. Okay. Remember when we started, we said in the methodology, we had client, exit, we had FGDs for AYPs, pregnant women, we had facility managers, AIs, interviews, and so on. So there are some questions which the assessment cannot answer, and but I will give the ones that we're able to do. In terms of the pillar on health information and the issue of the data, I think Roger has a presentation, but what I would say is, and this ties to what Dr. Dege alluded to in the morning. You see, for instance, USAID are using TXCAR, which is the population in care to allocate resources. But West Pokot has one of the highest stigma index, meaning identifying that one person has some costs that ordinarily in a place where there was no stigma, you would not face them. So there are some confounders that which if we do not address in programming, the indicators might not move with the traditional intervention. So those are the other things. The other things is, for example, cross-border. How much are we investing in across the board? Because we are serving the same population. Are the interventions across the border similar to what we are having? Yes, we've started our informal connections. We have WhatsApp group with our colleagues from Uganda. Already IGAD is supporting something, a cross-border mechanism. I think there has been teams in the county looking to address the cross-border issues. So there are confounders in this programming that I feel the study, the assessment itself was not powered to answer. Is something that probably we need to triangulate and be able to get that. I agree that yes, we have 14 modules, and we need to come up with the priorities. From where I sit, I think the priorities have emerged on their own. And they're also supported by available data from KDHS. For example, we know that malnutrition is one of our biggest issues in the county. Yes? So we expect that the rollout of BFCI, and I believe that's what informing the vision carriers that are supporting BFCI, because we are making a lot of progress in terms of the coverage of BFCI. So again, we are one of the high burden counties when it comes to open defecation. So we expect that CLTS and SANAT, which combines nutrition together with sanitation, is a priority, and that is why the vision carriers have worked on a protocol that is specific to West Pokot. I think we have one that we should be launching soon, indeed, or something like that.
So from where I see the technical modules have sort of distilled themselves into our priorities as a county based on our data and our realities. In terms of, as I said, the assessment was not powered to give us data on donor funding, for instance. But what came out, if you look at those handouts, was that there are facilities that reported that had not been funded. Okay. Right now, the other significant funding that we have, and my colleagues will add, is the one from the Danish government. And by arrangement and by design, it has been going down. But the number of facilities that we require for them to support in terms of operations and maintenance is going up. So that means what is available for OM for our facilities is actually coming down. So as our leadership tries to balance the financing of OM for all our facilities. Then yeah, so that is what I would like to say. So in terms of technical modules, I'm at a position where I feel now, in addition to those two, from our experience, and I must confess, I don't know whether you are done with the data on the ICHIS assessment that we are doing on the side. We were actually, when we are doing this baseline assessment, we were interested in how we were doing with regards to ICHIS after their training. And there were significant gaps after the training. And what was coming out was that what happened was a sensitization from management up to, and for some reason, the messaging that went out to the CHPs is that we finish household registration. So the use of the workflows that are dealing with assessments were not very well articulated. And I think around that time, the TOTs were really under pressure to deliver. And I think they did a very good job. But this is something that we need to revisit because it is a priority intervention and say, look, yes, that was a sensitization. What else can we do to ensure? Now we go to data review meetings, OJTs, and mentorship that we need to support to be able to ensure that the CHPs are actually adequately equipped to use the platform. So I think I will stop there. I'll just invite my colleagues maybe to respond to the other questions that might have been asked.
You're waiting for, okay, thanks. So I want to appreciate this good work that the county has done, really doing a lot of assessment and ensuring that we get the data where we are starting to work on. And I'm sure from this, we are going to get a clear roadmap on what really programming is going to look like in all the 12 sectors and pillars. One of the things that we then need to look at is how to make our PCN smart as we mainstream this work. Smart PCNs, as you also heard Dr. Salim mention, is quite a big gap in all the counties. We have a very few PCNs that are smart. This means that linking all the health facilities for ICHIS to the EMRs is still a big issue because of the high investment that is required. So one of the key asks to all the county leadership teams that we are looking at is looking at the requirements for digitizing the PCNs will be critical as we even move towards the shift aspects. And linking to this is to ensure that all the health facilities are properly licensed and accredited to ensure that they do the e-claims. If the facilities will not manage to be connected, they will not do the e-claims as required. So therefore, we may lose out if we do not finalize this. So there is an assessment that is being rolled out nationwide, and the national team is helping us helping all the counties through the COG to help the CHRIOs. There's a training that is going through, there's a tool that is being rolled out to help assess the requirement for digitization so that we really see where counties are, what are the gaps, and what are the requirements so that we can start rolling out and supporting counties to ensure the digitization agenda is achieved across. So therefore, from the county level is to also look at this kind of high priority area, because if you do not digitize the health facilities, linking them to form the ECHs to the systems, then we'll be able to really miss out on the e-claims and ensuring that service delivery will not be continued as we expect. So that is my request and comment. Thank you.
Thank you, Elijah, for the TA. Thank you, Dr. Maria, for that quite elaborate report. I think that really provides a roadmap to the next steps in as far as PHC implementation is concerned. I think Elijah has already preempted part of what I wanted to ask. But just to circumvent that question a bit, is to find out in the report what amount of information or what level of services are referred to the facilities since the inception of ECHs. We know that after a number of CHPs who are trained on ECHs, happen. And that means that whatever services they conduct at the facilities, then they are supposed to refer for those who have issues around NCPs, particularly referrals like after each training, CHP stopped using MH100, for example. So what did we find in our case? Did that come up? If it did not, then that is something that we need as a county and the rest. There seems to be a challenge when it comes to referrals from the community. The CHPs, and it's good they are here. Maybe it will also be important for us for them to share their experience. What level of interaction do we have from facilities?
And then the second, a general comment in terms of how the baseline assessment has been designed. If you look at the results, and it's not just here, it's how it was designed at the national level, it is very supply side oriented. So we are looking, someone says we are navigating, so we are looking at just what is happening within the health facilities, and so the demand side issues are not very strong in how we are doing the baseline assessments for the PCNs. So with that in mind, as we do our recommendations and design our work plans, we need to ensure that we unpack the demand. I don't know whether we intentionally go and get more information in terms of what are the bottlenecks and how we can design programs that are because if we just deal with this, we'll find ourselves more doing the same thing. We'll not have the paradigm shift that we are looking to get. So as we design the work plans for the PCNs and the recommendations, I think we need to have that in mind, that the baseline is very supply oriented. We need to unpack the demand side more to be able to achieve what we want. Then just to enrich the report and maybe subsequent communication materials regarding to the baseline, we need to include a dashboard, the VSP, the vital signs profiles. It gives a snapshot what is happening in the county in terms of primary healthcare services. I think it would be a good thing to include in our report. Then on supervision, I didn't see anything about community level supervision. So do we stop at the level 2, or do we go lower in terms of following up, even as managers, whether at the county level or at the sub-county level? And I'm asking this based on a discussion I was having with Nairobi County when they were reviewing the baseline tools for Kibra PCN that we are supporting. And we were having a discussion, and they were saying, some of them felt like, are we supposed to supervise community health services? Should we be going up to the community level? And I don't know, maybe you had that question also when you were reviewing your tools. But I think that is something we also need to ask ourselves and ask who supervises the work that even the chairs that are doing. We support them because remember it supports supervision. So it's not auditing them, but really seeing how can we support them better to be able to provide the services. The other one is a comment on MOH 100. I heard that it's no longer in use. And maybe the information would be, and we've had this discussion at national level also, that as long as we've not been able to digitize our health facilities, we need to continue using M1 or MOH 100 because it's a useful tool in terms of looking at our referrals from the community and back to the community, checking on complete referrals. And unless we have something that we can record that, then it will be very hard. I know with ditches, that in some places it's no longer in use, but in some counties they've insisted on continuing using it because there's no other way to track the referrals. So maybe it's something for the county to consider. Then for the technical modules, just to mention that, yes, there are many, but it has never been the expectation that every CHP should be taken through all the technical modules. It should be based on the context and the need. So, and I think that pressure should never be there. It should be on need and based on your disease burden or the issues that are affecting a certain context, then that's how we prioritize and progressively train the CHPs. Thank you.
Thank you for those very comprehensive comments. I think with regards with the issue of advocacy and at what level in terms of NHIF, I think for us, we want to be ready for business. And what does that mean? We need to have our population ready with identification cards and able to register once we sort out what needs to be done with the shift, which is on its way. So I think that's what it looks like. And for us as a border country, there was a problem initially with the issue of vetting and so on. But I think there was a policy declaration on how vetting will be done. And this has made the process of acquiring identification cards much easier. So that is an area where we need all the stakeholders to come on board. The registrar of persons to be able to be supported, or for partners in health to see maybe the necessity of joining that conversation and also to be able to engage. And that's why we were happy that the PHC advisory is really diverse in terms of its composition. And some of the critical drivers, like the coordinator of national government functions at county level, is actually a member of that council, and that is the county commissioner. So we hope once we gazette and operationalize all this, we'll be able to sort it out. In terms of social accountability, I think that is noted, Eunice, and in our mind, one other gap that we wanted to roll out, and initially we had been supported, is the use of the community scorecard, which gives us even more information, and we've had our partners from time to time, if we can support that in a sustainable manner. Of course, dialogue days traditionally, and it's a high impact intervention at that level. We need to ensure that we have quality dialogue days where the population actually demands their rights with regard to CHS. I like the observation you've made on the structure of the questions that were given. We agree with you. And maybe at the national level, you can be able to do something about this. For the VSP, we were hoping we'd have a ceremony about it. Yeah, because I think we attended, we were part of the county that was targeted for the initial process, supported by UNICEF, and I think there was a consultant who was working on the elaborate VSPs with regard to PCA. I believe our document is lying somewhere. So we would want to roll it out and disseminate the findings to all the stakeholders. The issue of community level support supervision really is it at the cracks of PHC. And it is a problem we've struggled with since time immemorial. How do we do it? And then it goes to the KPIs for our partners. Very few are able to go up to that level. And that is why we were hoping that the HSSS mechanisms would be able to support this. And we are glad that the USID mechanism serves CHS as a sub-purpose under their programs. So that is something which we are really looking forward to doing. I know we are running out of time. I don't want to add anything there. So Stella, hiyo ni moto ama you can survive? Ni moto. Okay. Ndege ni moto. Okay, let me, but because of your seniority, anything you say must be taken seriously.
Mine is a quick rejoinder to your response concerning community dialogues and also concerning supervision of community level. You see, the FIF Act, yeah, provides that 30% of the funds that are collected at the hospital level or, whatever facility charging should actually go to primary health care. Everyone agrees up to that point. But now you ask, what then is primary health care? Because when you talk about operationalizing primary health care, then this is the nitty-gritty, and that's exactly what the fund should do. Primary health care starts at the community level up to the sub-county level, right? And at the community level, these are the funds that are basically supposed to get dialogues happening, community action days happening, and support supervision happening. And you asked about sustainability. That is the only sustainable way. There's no partner who can sustain that. It just has to be government. And you already have an avenue through the 30% from F5. And I'm happy that West Pokot is among the lead counties in implementation of F5. You haven't optimized it, but there's still room to be able to optimize that and make more. But then the question we need to be asking is the how to operationalize that. But in terms of mapping out the funding, for me, that is the funding that should be able to support that. Yeah, because PHC then runs from community up to the sub-county level where they have. Thank you. Moto.
Yeah, I think the administrator of our fund is here, but we'll invite her to say one thing.
Yeah, thank you. I think I wanted to say something about the note I saw here, but I've corrected myself. But on your comments about the issuance of IDs, you said until we finish the, starting up all the PCNs across the country before that process begins, because we really have a challenge as we speak now, because the patients who are in care, HIV care, we really need to give them a unique ID. And what has been identified nationally is actually unique ID. I mean, it's the identification number. So the challenge we have currently, and it's called NUPI, the challenge we have now is that if we don't assign all patients that number, we may get into a point where those patients will not be supported, because I think nationally through NASCOP, they are saying that this data should be pushed, as it is pushed into National Data Warehouse, we need to be very clear on identifying the clients. So for us, it is an emergency, and we have been thinking, I think one of the issues we have been thinking to have on discussion is how to work with that, the department you mentioned, that are actually issuing IDs, that we should fast track that process. So I think that is something we need to really have some discussions on. If it can be started, the sooner the better. In fact, there are a number of patients along the border who have Ugandan IDs, and they don't have the Kenyan ones. At some point, we don't know whether they're actually Kenyans or they're Ugandans. The story is that it is easier to get an ID in Uganda than in Kenya. And I don't know, there may not be an active process to actually provide them with national IDs. So I think that's an issue really we need to look at and see how we can work on it, even before this other process is completed. Thank you.
Just to clarify, the issue of IDs is not tied to the PCNs. And I hear you, Senior. I think what we can do, because the patients on care is a captive population, we can organize in-reaches. I don't know how that will tie to stigma and everything else. I don't know how we can do it, because it's a captive population. They already, we know them by name, and they have scheduled visits to the facility. So an in-reach by the registrar of persons within our CCCs and ART sites can solve our problem. So I think, oh, thank you. So I think that is where we are. For me, as I invite Chief Officer to just make a remark, I would say one of the challenges that we've had with the implementation of the FIF is it adequate for the costed functions that we want it to do? So on paper, yes, we are saying 30%, but what is 30% against the costed implementation plan that these entire levels of care have? For example, we need to be very clear on the high impact interventions for a sub-county health management team. And each time we are looking at the performance of a health management team, we are seeing if they meet their stakeholders on a quarterly basis, because it is prescribed. Did they conduct a data quality audit for the facilities they are responsible over? Did they subsequently hold a data review meeting? Did they have facility monthly facility in charges meeting as they are expected to do? Did they go out to do quality support supervision? How are they doing the technical OJTs and mentorship? So those are the high impact interventions for those teams, and they are costed. I can tell you on average, we spend around 200 and something, 205 in a sub-county to host a monthly facility in charges meeting. So also the total amount in terms of what is available from 30% is also critical. So my point being that the partnerships must continue until such a time when the available envelope can be able to take care of our high impact intervention. And then we can be able. Let me invite our Chief Officer to just do. And I think I'm told the next session we are ready to proceed. So maybe you can just clarify. Karibu, Chief.
To enhance on the response that Dr. Muria has given, we have to be sincere. We are working within a very restricted physical space. In terms of health financing, we get about 2 billion shillings per year. And that is recurrent plus FIF combined. And 1.4 billion is salaries for contracted staff and P&P. We've not counted on wages for the casuals. And in terms of casuals, we are the second leading in the county with about 448 casuals. And their yearly pay comes again to about 48 million. So when you look at what remains, we spend again 220 million on health products and technologies, which is not sufficient again because the number of facilities that we had previously, the numbers have increased by close to 52 new facilities that we've just operationalized, meaning additional facilities come with additional funding. And from before devolution, we inherited infrastructure that had stalled from CDF, from national government. From the time of devolution, again for 11 years, we've had more than 50 stalled or incomplete projects, which we are also struggling to complete them and operationalizing them. So you find that what we have within our reach is close to 50 million to run the department in terms of referral systems, in terms of administrative. Again, you find that before devolution, we had only one public hospital and one FBO hospital that is serving close to 700,000 population, which is not adequate to serve as a county referral hospital. So we've had to build the capacity of 6 more other facilities And upgrading these facilities from a level 2 to a level 4 is a big investment. So as we speak of 30% of what we get from FIF, because the facilities that are that have revenue generating abilities are only 4, and their potential for 3 is minimal, because the backbone is only Kapenguria County Referral Hospital, which when we came into office in the year 2022-2023, the entire 4 facilities were able to generate about 70 million. Then we improved the first year to about 100 million, 93 million. In the second year, we've gone to about 116 million. So when you compute the 30%, that 30%, we're having deficit in terms of HPTs, because from recurrent, we have to shoulder close to another 60 million from FIF to support our hospitals, for us to be able to cushion level 2 and level 3, which are not generating any revenue. So if you subtract 50 million from 100 million, you remain with very little money. We have to support sub-county health management teams in terms of operations, because they don't have any other source of income and they are not factored in the recurrent budget. So we have to support them to run with some funds. So when we are bringing operationalization of the community units, committees, to be facilitated using the 30%, it is not realistic. We will struggle unless for the suggestion that was given by Dr. Murie and by the CHMT, that maybe meanwhile, as we struggle with the financial constraints that we're experiencing, we have the sub-county management teams do supervision both for the facilities and the community level. And even at the community level, the health facility management committees at the dispensary and health center levels help us to oversight what is happening at the community level as we continue to resource mobilize on how to boost our revenue, and at the same time, as we look for means on how we can be able to improve our own source revenue as a department. So we are looking at your support, as we also see on ways we can be able to improve on efficiency to collect more. So I'll be able to give a summary of the roadmap of what we think can be able to help us in terms of boosting our own source revenue after a small presentation of a documentary that will take us about 10 minutes. And then if
Ladies and gentlemen, welcome to the Primary Healthcare Exhibition, Transforming Healthcare in West Pokot County.
His Excellency the Governor, Yuri Will Manifesto, put up a plan of the department which managed to get the highest budgetary allocation, 22 billion, from a budget of 7.6 billion.
Today, we are excited to showcase the remarkable progress made in the healthcare system of our county, in line with the national government bottom-up economic agenda. As part of this agenda, the county has prioritized primary healthcare as the mode of delivering health to its people.
Among the things we are hoping to achieve is get health down to the community level, make sure the health is accessible and it is cheaper for the common wananchi.
To ensure accessibility and quality of care, the Primary Healthcare Act 2023 has been enacted.
We are one of the county whereby already we have Community Health Services Act in place. And having the FIF Act, it accelerates service delivery in our county.
With the support of UNICEF, the county government has successfully established 5 primary care networks. These networks are designed
basically.
In West Pokot now, I can confidently say.
Ingine ambayo tunaona hapa imejengwa mzuri sana ni ya wanaume. Wakati wa muda hiyo yote tumekuwa hapa, wamekuwa wakichanganya wamama na wanaume kwa ward moja. Lakini tunashukuru sai serikali hii imejenga ward kubwa ambayo itaweka wanaume sehemu yao, wamama sehemu yao.
Mimi na hapo tutai pei. Otinikile tai atoma kwa jekereleji tiki kale. Olombe sai atoma kwa jekereleji tiki roite bewa ngale jembete. Kutama kategoria anda the way kutangai kitale krora aranya the project.
The second network is Kapenguria Primary Care Network.
It is not the way it was 10 years ago. You'll find that primary unit is working, the theaters have always been expanded, the deliver is well done, and you can see the whole infrastructure that is being done in the country.
30 patients in dialysis with 5 dialysis machines. We have a number of serving them. We also have critical care and emergency, which is complete. We are only awaiting commissioning of the structure. ICU is up and running. That was not there before. Another structure is a radiology structure that's almost approaching completion, that will be able to house MRI, CT scan, PET scan, mammograph, and then expanded ICU from 3 to possibly 8 beds, and 2 more theaters will be in that structure. What's ongoing at the moment is a new structure that's going to house mortuary. What we have at the moment as mortuary is a structure that was built way before 1976 that can only house 6 bodies. The county is building up a new structure that will be able to house more than 50 bodies. Upcoming structure that will be a game changer in West Pokot and their region is that the county is planning to bring up a new structure that will house mother and baby complex. It will be a 300-bed capacity structure that is going to be co-funded by the county and our partners.
The mini hubs are Kanyarkwat, Serewo, and Makutano health centers.
We are currently serving our neighbor Trans Nzoia, and also on the other side we serve Uganda. So most of our clients wanatoka Uganda. And then we are also taking from the other small dispensaries like Adrukoit. Tuko na pia Cheptio ambao wanakuja upande huu. We want to thank the national government and also the county government for such an infrastructure.
Tuko na mahali pa family planning ambayo itasaidia kina mama. Alafu pia tuko na maternity hapa ambayo itatusaidia wamama. Maana hapo ama hata tunapoteza watoto, lakini kwa sasa tunaona mambo itakuwa rahisi na tunamshukuru mheshimiwa kwa hii kazi ambayo amefanya.
The third network is Chepareria Primary Care Network with Chepareria Sub-County Hospital as the hub.
Chepareria will serve as one of the hubs for a good number of facilities. We have 27 functional facilities, 2 faith-based and 1 private. We have two hospitals. That is Chaparega Sub-County Hospital and Otum Mission Hospital. In Chaparega, again, we have the British ward as we look for the ward making sure that Chaparega is one of the PCS. One of the modern lab in the county is the Chaparega lab, serving over 100,000 population at the catchment for this sub-county hospital.
Wenye alikuwa anaenda transfer huko Katenguri alikuwa anachukua muda kufika huko, lakini kwa saizi imerahisisha hata pesa yenye watu walikuwa wanatumia kwa mahitaji yao inakuwa ya shughuli ya kutumia nyumbani. Tumefurahia wa kutujengea maternity kwa sababu tulikuwa tunafinyana watoto wanaume pamoja na wamama wote. Sasa tumeshukuru sana, especially wakati mama anataka kujifungua, daktari alikuwa anachukua suka na kuzidi wa mama apate kujifungua, lakini kwa sasa tumefurahi kabisa.
The fourth network is Kabich Beach Primary Care Network with Kabich Beach Health Center as the hub.
Initially, we used to just have only one ward, which was catering male, female, and children combined. So we didn't have enough privacy. But currently, if this building will be completed, then we are going to have privacy, and we encourage our mothers to at least come in large numbers to be treated at the same time to deliver from here.
Sasa saa hizi tumefurahi kwa sababu tumepata ward. Wasichana wetu mapatiti yetu yote saa hii watajifungulia wapi? Hapa.
The fifth network is Sigor Primary Care Network with Sigor Sub-County Hospital as the hub.
We have about 46 books that are served by this hospital. And as you know, we have received a lot of support from the county government. Currently, we have a new lab here that we just launched the other day. We have a pediatric ward that is new. We have a 32-bed capacity new ward, medical ward. And that has really helped this hospital because we now have women and men in different wards. And the capacity has doubled our inpatient from 40 to 96.
Lab no serikali takutegejia kipi mabi yete kewanga kasi yete isapa nyembe yete iwe nyetan kau maminya transport ja moy la awena nenya kore la woni ka mo wan lo maminya gisanno ndamo yereni wolta rivaro
wagonjwa ya Kalasa walikuwa wanaenda Katiliba Baba Basigor County Hospital, lakini wale vitu mingi inaendelea, tunaona hata ingine huko health center mwingine
now putting them are some of our spokes in this region.
The sixth network, Alale Primary Care Network with Alale Healthcare Center as the hub, is pending.
Being the only referral facility in this area, which is yet to be opened, we expect that it will really assist people of this area. Now, our referrals currently, we are taking to Uganda, that's Morocco.
The mini hubs will be Kasai and Kauriong health centers. Through these primary care networks, we aim to provide comprehensive, accessible, and quality healthcare for everyone in West Pokot County.
We have managed as a county to do some improvement to capacity building to those PCNs so that it qualifies to run as primary care networks. We have medical officers in those PCNs, and we are looking further to capacity built by recruiting more.
Operationalization of the Community Health Services Act 2019 by the county government has ensured that 2,423 CHPs are on a monthly stipend of 2,500 Kenyan shillings each. there's a counterpart funding from the national government translating to 72,690,000 Kenyan shillings per year. We have rolled out community health promoters to assist us reduce the disease burden at the bottom of the pyramid at the household. In this county alone, I am aware that we have 2,583 community health promoters. And out of this, they have registered 44,800 households. Kwa wamama wenye wako wajawazito, tunatembelea hao kila wakati, tujue hali zao. Tangu akiwa na mwezi 3, tunapea referrals waende hospitali waanze clinic. Mtoto tu akizaliwa, tunaenda kwa huyo mama, tunaangalia vile hali yake iko, na tunaambiwa vile ananyonyesha mtoto, akuwe keen, anyonyeshe mtoto kabisa mpaka afikishe mwezi 6. Imeleta huduma ya karibu kwa kijiji. Ile sasa hatuwezani nayo, tuna refer ili aende apate huduma kwa hospitali.
High blood pressure tunapima na kilo pia tunapima kila mtu, so kila mtu anapata huduma kwa wakati na tunamrefer yule anaye kuwa na shida mingi.
We have again invested through the partnership with the national government to allocate money to pay stipends for the 2,501 community health promoters. And because we know they will play a major role when it comes to service delivery at lower levels.
Chakula utaweka tu kwa nyumba tayari, alafu kutembea
kila wakati, maana tumepewa nguvu ya kutuwezesha.
The CHPs will spearhead community services aimed at prevention of ailments such as Kala-Azar. This is another flagship project actualized by West Pokot County government.
We are looking at how we can better structure the health facilities to work together in a network wherein the hub, being a level 4 facility, is going to offer specialist services and support the lower facilities, the health centers, which will be the spokes, and the health centers and the dispensaries will be the spoke for the hub, which is working as the main coordinator for all the activities within the PCN.
We can boost off key specialists that were not there before. At this moment, we have a neurosurgeon who was not there before. We have an ENT surgeon who was not there before. We have ophthalmologist who was not there before. Myself, orthopedic surgeon, who was not there before devolution. We have general surgeon who was not there before. We have 3 obstetricians and gynecologists, and they were not there before. We have 2 pediatricians, again, they were not there before. And then we have 2 physicians.
In health, you can see substantially very good development that has been done. And the general public is appreciating the great development that has been done in that sector.
We are committed to ensuring that no one is left behind in our pursuit of healthier and more prosperous future.
So at the exhibition site, partners supporting various programs will also be presenting or will be showcasing documentaries in the various areas that they are supporting. A lot has been done for the last 20 months. And in the remaining few years, we are sure we will be able to move health from somewhere to somewhere better. facilities. There are very many that we've been able to implement in the last 20 months. And it cuts across all the 20 wards. We have 20 wards, we have 6 sub-counties, and in the governor's manifesto, number 1 list for him was to upgrade Kapenguria County Referral Hospital to be a level 6 hospital. And we've started that journey, and you've just seen the pictures. For the first 2 years, we are doing a radiology department that is fully complete right now, which will host CT scan, MRI. We have also a radionuclide room there. It will also host the various X-ray machines for mammogram, for OPG, for general X-ray. It will also be hosting 2 operating theaters and an ICU with extra 8 beds. We are also hopeful to have a surgical ward in the last floor of that building, and we will actualize that. In the second project that we are also doing for KCRH is a modern mortuary that is also at completion stage. Probably in the next 2 months, 1 month, we will be able to commission, considering that we are having a major project that is a mother and baby complex that we are just projected to, which is a project that we are starting implementation in the current financial year. So we are waiting for the budget to be live, and then we start the procurement process. We are hopeful that is a project that will be co-funded by county government in support of saving mothers. And we are looking for more partners to assist us in the implementation of that project. It will be a 300 bed capacity. It will also host oncology department, because it was the vision of His Excellency that before he finishes his second term, oncology department should be running in West Pokot County. Thirdly is that we are operationalizing the emergency unit, which will be done within 2 months from now. And we've beefed up in terms of equipments, specialized equipments at KCRH. And we've stated what we require to take KCRH from a level 4 facility, from level 5 facility to level 6. And we are doing resource mobilization to actualize that dream. Being the only hospital in West Pokot sub-county, we are putting up a second hospital within the municipality, which is Makutano Health Center, which will start as a health center, but we have a dream to have it being upgraded to sub-county, probably by as we close the 5th year. And we have also done upgrading for Kanargat Health Center, which is fully equipped. We are waiting for the national government to come and commission, because it was supported by Equalization Fund. We are also having Serao. These are mini hubs that will support the main hub, because KCRH is the county referral hospital. We didn't want it to be a hub, but meanwhile it will act as a hub for West Pokot sub-county, but we are building the capacity of Serao, Kanargat, and Makutano Health Center. For Sigor sub-county, it is a hub. We will be having 2 mini hubs. We will be having Surumben, which is a health center, but after commissioning new projects that are at completion stage, we will be following on the issue of accreditation to be a sub-county hospital. We are also having Tamkal, which is serving 4 counties. Tamkal serves West Pokot, Turkana, Baringo, and Elgeyo Marakwet. Some of the structures that was posted is for that facility. It is at 80% completion rate. In Pokot North, we operationalized the second sub-county, which is Kacheliba. The headquarters for Pokot North is Alale. Alale also is complete. We are supported by Equalization Fund. We are waiting for a date to be given by His Excellency for the national government to come and commission. It will be fully equipped. So those are facilities that can be operationalized within the month of September. Mini hubs for Pokot North, we are having Kamketo and Kasei. And these are facilities also we are earmarking to the sub-county hospitals in future before the close of the 5 years. Then in Kacheliba Sub-County Hospital is a level 4 facility with 6 major ongoing projects. That is an oxygen plant, a pediatric ward, male ward, kitchen is complete, and the theater we've already commissioned last year. So mini hubs for Kacheliba, we are having Kauriong and Konyao. So we are supporting them in terms of infrastructure and equipping for them to be sub-county hospitals to be able to support these facilities. And then for Pokot South, we also operationalized Kipkomo, which serves 2 wards, that is Batei and Chaparere. Chaparere is a sub-county hospital. It is the next after Alale in our priorities for upgrading. But through a partner from Australia, VAMED, we are expecting them in the month of September to assist us in expansion and renovation of the current maternity, which will be starting next month. But that is where we are putting our efforts for the financial year 2025-2026. Mini hub for Kipkomo is Chepkobe and Yolateke. Then for Pokot South, it is serving 2 wards, that is Kapach and Leland. The main hub is Kabich Beach. We are improving Sina and Kaptabuk and Tapach to be many hubs for that sub-county. So this requires a lot of investments to be able to support these facilities to be fully operational as level 4 facilities. And with a little resource from the county government, from partners, we'll be able to reach far. I want to recognize the big support that was extended to us by DNDi. When they found us, when they saw what we were able to accomplish within a short time, they extended to us a support in the last financial year, and we were able to do a project in a record 9 months. And they constructed for us a 32-bed general ward in Sigor Sub-County Hospital. We really appreciate it, and they also extended support for us in Kacheliba with partial funding for modern kitchen. So, and we are hopeful that with all of us here, you can extend support to us, or you can tell a friend to support us. The need is enormous, because even if we are focusing on the paradigm shift from curative to preventive and promotive, we must have a facility that is able to provide quality care at least at each sub-county level, to save our patients from traveling very far and from incurring a lot of indirect costs to seek healthcare services from far facilities. At the same time, we are having 20 wards. We are upgrading one facility per ward to be a health center, at least to have an inpatient facility and a maternity, so that within a ward, the other dispensaries can be able to access RAMCA services, and they can be able to access inpatient facility. So far in 20 months, we've completed 15 maternities. We've already commissioned 3. We are having 12 that require equipping. In the current financial year, we got support from the national government through Equalization Fund, and the Department of Health was lucky to get support for upgrading of 11 facilities with full equipping, and probably 6 of them will have networking. One of the biggest challenge that is hindering us from collecting adequate revenue from the existing 4 hospitals is efficiency. The only facility that is fully automated is Kapenguria County Referral Hospital. So the 3 other sub-county hospitals, we are still doing manual collection. So there are a lot of pilferages and inefficiencies. So that is where we want to invest in the current financial year. We've done some proposals and requests to partners and friends. Hopefully, we are having a promise that probably Kacheliba and Sigor may get support in the current financial year through National Treasury. So we are hopeful if we can be able to extend that support to the other 3 hospitals, then we can be able to increase our revenue base to assist these hospitals, at the same time have enough money in the pool to support primary health care. So we have an ambiguous plan, and all that we need to do is stated in our CIDP, which was commissioned last financial year, and we are encouraging all of us that let us look through the CIDP that was commissioned last year. If there is anywhere where you can extend a hand, just choose. Even DNDI supported a ward and said, we have seen there is a kitchen in the CIDP, can we do partial? And we committed to complete the remaining part. So for the facilities that have been earmarked for upgrading, we've all listed in the CIDP. We've been extracting in the ADPs what we are able to do in each financial year as we go along. Otherwise, I think from the other documentaries as we go through what is being exhibited, we can be able to see what will be showcased by the partners that are supporting health. But West Pokot County has a big potential. And if we strengthen our collaboration as partners and stakeholders in health, West Pokot can become the best and model county in Kenya in terms of provision of healthcare services. Asanteni sana.
Thank you, Chief. Let's appreciate her once again, Makofi. Yeah, thank you so much. I think we have really tried to catch up with time despite the late start that we had. And I think it has been a success, and we have set the stage for the climax, which is going to be tomorrow. I think just one announcement. If you look at the program, the last item that we're supposed to have is the feast, the gallery walk, and because of time, maybe we are going to break for tea. Then we can have the gallery walk as we are having tea, because I'm sure we are going to have to repeat again tomorrow once the bosses are here. So I think it's going to be a good time to familiarize ourselves with the booths which are out there. Maybe CC, any announcement?
Okay. Thank you, Director for Health. I wanted to appreciate each one of you, the presenters, for the commendable presentation, and for the participants, because I really learned a lot, and I also believe we have learned a lot through the presentations and even asking questions and giving comments. Because of time, I didn't want to labor much, but I'm requesting that we come to an end of our today exhibition as we begin for tomorrow. I mean, when having meetings, you need to see the condition of the participants. And I know here tuko na wazee, tuko na watu ambao tukizidi zaidi wanashangaa why we are insensitive. Otherwise, allow me to take this opportunity to thank everybody. Our bosses is on the way, already one is at airport, meaning that tomorrow we'll be able to proceed with them. Guys, thank you so much for today, for those who came early, for those who might have come a bit late. I know tomorrow all of us will be here as we continue with our tomorrow section. I didn't want to talk much. My humble request is that our partners, you may see that we are ambitious, but we count you in our journey, and we have an expectation that we realize the objective or the goal we are intending to get as a Department of Health. Because in the government manifesto, this is where we really wanted to achieve apart from any other. Right, thank you so much. Let me, because of time, we have all agreed that TIC colored work should be combined with the T, because with time is 6 minutes to 17. Right, thank you.
Thank you, Waziri. Makofi. Thank you. So I think we are well guided, and as we walk in the exhibitions, if there are suggestions that you can give us to improve on one or two things before tomorrow, we are welcome to take those suggestions. So let me invite our pastor for today to close for us. Karibu.
Asante. Bwana asifiwe. I want to take this opportunity to thank every one of us kwa kuvumilia. So tujue ya kwamba Mungu ametuwezesha, ametupa nguvu, na kwa ile nguvu tulianza nayo asubuhi, basi tushukuru Mungu kwa kutupa nguvu nyingine ya kuendelesha kesho. Kwa hivyo tuamini na tuombe. Mungu Baba, Mungu Mwana, Mungu Roho Mtakatifu, ni katika jina la Yesu Kristo twaje mbele zako tena jioni njema. Tunasema ni asante, umekuwa pamoja nasi tangu asubuhi mpaka wakati huu, kutuwezesha kwa mambo yote ambayo tumeyafanya siku ya leo. Tazama Baba, ni wakati mwingine tunaenda kutafuta mahali pa kulala kwa pamoja na kila mmoja wetu. Wale ambao watasafiri wape safari njema. Tutakapokutana kesho tena Baba, tushukuru jina lako takatifu kwa sababu ya wema wako na kwa sababu ya uaminifu wako. Asante kwa kikombe cha chai ndio kikombe letu, tunaomba upate kubariki katika jina la Yesu Kristo ambaye ni mkombozi wetu. Amen.
So what time are we meeting tomorrow? I think we need to agree on that as we leave. 8:30, 8, 7:30, 9, 8:30. Thank you.